How is everybody? Good, very good, very good. Anybody have any problems over the weekend with your homework or what you're learning or anything? Okay, you're still having problems or? Okay. You don't have an ID until you've already registered. Your ID is established when you register for the test. Right, but you have to go through the registration process. It has to be processed, and then they create your ID for you. So you won't have one when you first register. You don't have an ID yet. So was it like a login screen that you were looking at? Okay, at the very, very bottom of that login screen, it'll say register. You have to click on that to create an account. Okay, but see me after class. Okay. All right. Any other questions? Any other questions? Okay, so over the weekend, you had chapters 5 and 6 to read. Let me get your scores for 5 and 6. Doodling? Ariella? Thank you. Jake, can you throw this away, please? Okay. Callie? Carol?
None and this one.
Thank you. Evelyn? Thank you. Courtney?
None and one.
Thank you. Christian?
No, I forgot to check number 5. 1 second.
That's fine. Kayla? Virgie?
I have chapter 5 mistake is 2 and chapter 6 is 1.
Thank you. Diana? Faith? Teresa? Kaylee? Tammy? Christina? Thank you.
Both mine are as well.
Okay, thank you. All right, no questions on the homework? No questions?
About my mistake.
Okay, what's your question?
Number 2, if a dementia patient is hallucinating, you should correct them immediately, tell them they are hallucinating, they will direct the patient to ignore the hallucination, and then literally call the doctor. That's what I answered.
Okay, so hallucinations can actually be pretty common for a wide variety of medical conditions. Sometimes we don't get enough blood to our brain because our heart just doesn't pump well. Sometimes we don't get enough oxygen to our brain because our lungs aren't working well. Sometimes it's a nervous system problem, right? The neurons aren't connecting. Sometimes it's a dementia problem. So sometimes it's a medication problem. Hallucinations can happen. So what do we do when hallucinations happen? Well, if you tell somebody, hey, you're hallucinating, that can actually make things a little bit worse. Now, that's usually not the right answer. What was the first one on there? The first answer?
Number 3. Here. Correct them immediately.
Okay, so let's talk about correcting them immediately. If we have somebody who is hallucinating, and let's just say that they're saying those children are being very loud. Now, there's no children. There's nobody playing. This is an auditory hallucination that they're having, and actually very common, by the way. Instead of saying there are no children here, what you're doing is arguing with them. Now, have you ever tried to argue with an adult? Anybody ever have an argument with an adult? Yeah. So think about your own family, right? Have you ever argued with your significant other or your brother or sister or even your parents, right? Two adults arguing is very different than a parent and a child arguing. Okay. A parent and a child arguing, parent's always going to win. There's a power dynamic there. Two adults arguing, they're on the same level, right? So two adults arguing means that somebody at your station is telling you you are wrong. You are likely to dig in. You're not just going to go, oh, well, I must be wrong. You're right. Everything's fine. No, you're like, let me tell you why I'm right. And you are now digging in. Make sense? We tend to forget this. We tend to, when we're working with patients, we want that parent-child relationship. We want to tell them what to do and we want them to do it. That is not the relationship that we have. That's what we want because that makes our life easier, but that is not what we're dealing with. What we're dealing with are two adults. If you tell another adult you're wrong, it's not going to go well for either of you. Okay? Good morning. It's not going to go well for either of you. And you can see this in any social media comment section. We see this all the time. Somebody posts a comment, somebody else says you're wrong, and now it's on. Why do we not understand that in a clinical setting, these are adults? So we tend to forget this when we're working with patients. So if you've got a patient who has dementia and you tell them, no, there are no children here, you have just told another adult they're wrong, and they're going to explain to you all the reasons why they're not wrong. Did that solve the problem? No, it didn't. So that's not the right answer. We try real hard not to tell another adult that they're wrong because it's not going to solve anything. You're not going to convince them. Now, the right answer, going directly to the DON or calling the doctor, that's not our role. We report to the nurse, not the DON or the doctor or anybody else. We report to the nurse. That's what makes that answer wrong. So the right answer here is just to try to get them involved in something else. Distract them. And this is our answer with dementia 99% of the time. So when you have a written test question, if your patient has dementia, is hallucinating, is acting out, it is displaying negative behaviors, our answer is generally distract them. Get them off of that. Take them for a walk, get them involved in an activity. Let's have a snack. Redirect is the word. Redirect them to something else. And you will find that using that strategy, you'll have a lot less conflict with the patient. Okay. Good. Does that make sense? Okay. Yeah. And dementia, you will have quite a few questions about dementia on the test. Remember that when we're communicating, there's two different forms of communication, guys. And I saw a lot of comments on one of the video shorts that was put up this week or last week, I don't know when, but a lot of the comments were on, well, I was talking about consent in the video, how it's important that we get consent from our patients. And a lot of the comments were, well, you know, these patients have mental deficiencies or they have dementia or you know, there were a million comments about that, but that was not what I was talking about. I was talking about competent adults, right? Incompetent adults, that's a whole different subject. That's completely different. That's irrelevant to what we were talking about. Competent adults, we're going to communicate with them like an adult. An incompetent adult, somebody with mental illness, somebody with dementia, somebody that doesn't have the ability to make good decisions for themselves any longer, those individuals we're going to communicate with differently. We don't ask them yes, no questions. I will never ask a dementia patient, do you want to take a shower now? That is not a good question because they will always come back with no. That's the way that they are trying to reclaim some of their autonomy. They have lost their autonomy. They are trying to reclaim it by using the word no. So we don't use open-ended questions with dementia patients. What we say is, would you like your shower now or after lunch? That is not a yes, no question. That still gives them a choice. It allows them to express autonomy, make a decision for themselves. But one of the answer choices is not no. It's now or after lunch. Does that make sense? Good. So when we're talking about patients with dementia, confusion, hallucinations, delusions, all of those types of issues, that is not a competent adult. That is somebody else. And for those individuals, redirection is the name of the game. Distraction, interaction with activities, or getting them active in some way. Bopping a beach ball around can be a great distractor, or a balloon. Behind the desk of the nurse's station, a lot of times you'll see a beach ball. It'll just be kind of back there. And when you have a patient who is getting a little antsy, a little irritated, starting to act out, just kind of bat the ball around and then just bat it over to them. It is, for some reason, an ingrained response. We don't like balls to touch the floor. They'll bat it back. And now we have a game. And we're no longer focused on whatever it was that they were spiraling on before. Make sense? Good? Okay. Class is half over. If you have not registered for the test yet, you probably should. That's going to be important to you. Game show will be not tomorrow, but next Tuesday. So week 4, which is perfect timing for you guys. Week 4, you might want to put it on your calendar, because these questions for the next game show are going to focus on safety. So you're going to get to see how questions on the state exam are worded regarding safety, how they're going to give you those types of topics, and why certain answers are really, really bad to pick. Okay. I'm not going to go through the review for today. I don't think that we need to. You guys all remember all of our principles, correct? Does anybody want me to go through the review? I want to give you guys a couple extra minutes for practice today. Okay, good. All right, so if you look on page 80, our very first skill today is going to be range of motion, hip, knee, and ankle. Do you guys remember the range of motion that we've learned so far? We learned shoulder, and we learned elbow and wrist. Today, we're going to learn hip, knee, and ankle. Everything that we learned for shoulder and elbow and wrist is going to apply here too. So it's not learning a whole new skill. It's just applying what we know to a different body part.
This is off topic, but online, there was something about a discounted CPR class. Was supposed to be the 3rd Monday into it. Would that be today?
Well, no, and I'm sorry, I've got to find that. I used to do the CPR when we moved in here with Julie. She does the CPR now, so that would have been for my class, and I'm not teaching it any longer. But Julie does give you a discount on CPR if you use the QR code. Do you remember the first day handout, the blue sheet? On the bottom of the blue sheet is a QR code that leads you directly to her registration portal for our students. So it automatically bakes in that discount. Okay, you're welcome. All right, so along the bottom, you can see this skill should take somebody with your level of experience 4 minutes or less. This is going to be done on another live testing student. That person will be laying in bed to begin the skill, and this is not a documentation skill. So we just go in, do the skill, do our closing, and end. No documentation required. So if you look at the step-by-step instructions on page 81, it's a short skill. Care plans at the top. There's no supplies necessary. I love range of motion. They are the easiest skills to do. And as long as you're following the care plan, it's really hard to mess them up. Follow the care plan. So here's our care plan. It says, provide the following range of motion exercise to the residents: right hip, knee, and ankle. Right hip, knee, and ankle. Are we doing the left? No. And it's really important that we remember to follow that care plan exactly. Now, the care plan is going to also tell us which exercises to do on those joints. And it tells us flexion extension. Do you guys remember flexion extension was up, down? So we're going to take the hip up, down, the knee up, down, the ankle up, down. But this is going to be done a little bit different than that. And I'm going to explain why. We don't isolate the hip and the knee independently. We actually exercise them together. And I'll explain why in just a minute. Tells us to do 3 repetitions of each exercise, and the patient is not able to help with the exercises. There's nothing new for us to learn here. Nothing new. We know all of the principles involved. And in fact, we know, good morning, we even know the skill-specific principles involved. So nothing really to learn here, but we will review. So with range of motion, we follow the care plan. It's going to tell us which body part, which exercise, and the number of repetitions. And to review, anytime that we lift from below with a flat palm. We never grab from above. When you grab from above, you have to dig in, and that can cause bruising and tissue damage. But even more importantly, when you go to lift, all of that weight, remember gravity is pulling everything down. That extremity is likely to fall out of your hands, and then injury can occur as it falls down. So we never lift from above, always from below. Usually near the joints is the best place. Move slowly and smoothly, and we always want to return to the start position. We need a full range of motion. So we always go back to start. So when we're moving away, we go to the level of comfort of the patient, but then we return all the way back to start. So for instance, if I'm doing abduction, adduction on the right shoulder, and we get to here, and the patient goes, now I know I'm not going to go past that, but I'm not going to come here and go back up. This is not a range of motion. This is flapping a wing, okay? We want to go all the way back to start. So up, all the way back to start. The next one, up below the level of pain, all the way back to start. Good? Good. That's going to apply to all body parts.
So if this is not flexing, then what would flexing be?
Okay, so flexing is a bending of a body part. Okay, so look at my shoulder, right? So my arm is down here, and my trunk is over here. This is bent. Our shoulders are in a naturally flexed position. But our elbow isn't. Our elbow is in a naturally extended position, straight. So to flex the elbow, I would have to do this to bend it. To extend it, I would stretch it out. Extension. Flex, extend. Flex, extend. Good? Good. If you remember on when I taught you the very first range of motion, I had everybody stand up and I told you to extend your arm above your head like you were asking a question. I use that word very specifically because that's extension, extend, extension. Okay. You actually intuitively know this. I just have to bring it to your attention, okay? You know the terminology, you've just never applied it to this topic before. Good? All right. Flexion extension is up, down. Now, when it comes to the hip, we're going to go into this in detail in just a minute, but we're going to flex both the hip and the knee together. And this is actually what it looks like somebody is climbing upstairs. And I'll explain why in a minute. Okay. So when we are flexing the hip and the knee, we don't want to keep this leg straight and just pivot up and back down. This is what that would look like. We don't do this. The reason is we have nerves. We have a spinal cord that goes down the middle of your back. It gets to your lower back area and it branches off into 2, 1 for each leg. Now, this is pretty tight. Think of a rubber band kind of held, not stretched, but held tight. Good. Now, if I lift the leg straight up, what that does is it pulls this nerve tight. Now, when you're young, this is okay because everything's still pretty elastic. Have you ever gone to grandma's house and pulled a rubber band that was in her junk drawer 40 years ago out? It's no longer stretchy. In fact, if you tried to stretch it a little bit, it'll probably snap on you because it's pretty brittle. This is what happens as we age. When we're young, our nerves are very elastic. They will stretch with us. This does not hurt a kid at all. In fact, kids are really proud to show you just how far they can stretch. And that's great because they've got very elastic nerves that move with them. But as we age, those nerves get more brittle. And you'll see this in middle-aged adults. You ask a middle-aged adult to touch your toes and they get to like here. And that's about as far as they're going to go. That's about it, right? They're not going to go all the way down because that pulls on this nerve and causes pain. Well, we have the same thing when we lift one leg straight up. You're pulling on that nerve. This can cause something called sciatica, which really hurts the patient. And sciatica causes inflammation that can keep that nerve inflamed or under pressure for a very long time. I'm talking months to years. So this is not an action that CNAs do. To prevent this from happening, if we go back a slide, if we bend the knee at the same time that we bend the hip, then it keeps slack in that nerve. It keeps that nerve from being pulled tight. Okay, good? Good. All right. Flexion extension is up, down. So when we have finished with the hip and the knee, we're going to do that together. Then we're going to move on to the ankle. We're going to lift that ankle off the bed just a little bit. Because if I have the patient's foot laying on the sheet and I bend it forward and then back, it's going to slide against that sheet. And that can cause abrasions or skin tears. So Maid Simon says, I passed my test. I so really appreciate your help. I participated in your live class and watched your video. One of my skills was range of motion. Well, congratulations to you. Congratulations. Great job. So proud. So when we move the foot forward and back toward the head, and it's a gentle stretch. We're not trying to force anything that's not already happening. Okay. Gentle stretch. When we do that, we want to lift that heel off the bed just a little bit. You don't have to like lift the whole leg. Just get the heel off of the bed. Even this much is fine, just so that heel isn't scraping. So if you just slip your hand under that ankle before you position it forward and back, that'll take care of that abrasion issue. Abduction, adduction, not on this care plan. We're not going to do it for this exam, for this patient for the test. But to abduct the hip, you would just bring it out and back in, kind of like this, like you're making a snow angel. Okay, good. But we're not doing that for the state exam. We're also not doing rotation because our care plan didn't tell us to. Now, rotation of the hip is different from what you would think. We tend to think of rotation as kind of like this, right? Doing circles. That's actually not a good rotation exercise. To rotate the hip, a much better exercise is to actually roll it in and roll it out. Roll it in and roll it out. And that actually works deep in that hip abductor. And it kind of looks like you're doing the twist, right? So that's kind of what it looks like. Okay. But we're not going to do that. Why? Not on the care plan. Yeah. Along the way, we're going to ask about pain. Are you having any pain or discomfort? We want to watch your face for any grimacing or wincing or any signs of pain. Just make sure you're watching your patient's body cues when you're doing this. Not all patients are going to have the same range of motion. Good. We're not there to make anything better. We are simply there to maintain what they've already got so it doesn't get worse. All right, so we're going to use all of those principles to check off this checklist. We're going to follow our care plan and only exercise the joints indicated and only on the side indicated and only the exercises indicated. We're going to do our opening. Knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm your CNA today. How are you? I'm here to do some range of motion. Is that okay? Awesome. Let me go open your curtain or close your curtain, wash my hands, get my supplies. I'll be right back. We're going to decide if we need gloves. Now, for the test, your patient is fully clothed, holding on to all of their own body fluids like a champ. You do not need gloves for this. If you were working on this patient, however, and she is dressed in a hospital gown and incontinent, would you need gloves? Yes. Okay. It's not based on the skill. It's based on the person you're doing the skill on. Then we're going to follow our range of motion checkpoints, which is lift from below, slowly and smoothly, return all the way to the start position. Flexion extension is up and down, and monitor for pain. And then we'll do our closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Here's your call light. Bed's in the low position. Your environment is clean. You're covered. I'm going to open the curtain, go wash my hands, read my care plan one more time, make sure I don't have to make any corrections, and then tell the evaluator my skill is done. That's the whole skill. It's almost all opening and closing, with just a very little bit thrown in the middle. Good? Yes. Mm-hmm. Nope. Nope. And you can do this with shoes on. Now, if they're wearing cowboy boots, that's going to be a totally different thing. Please don't wear cowboy boots to the test. But do you remember on day one, I explained to you how the test is structured? Well, one of the things that I told you is they take you into a waiting room, they check you in, and then they disappear for a while, and they have to pair you up into groups. This is actually one of the things that they look at. They will look at your shoes. They know after you are checked in what everybody is wearing, what your shoes are, what your mobility levels are, what your size is, and they're going to use all of that to figure out how to partner you up. Now, if you get range of motion, hip, knee, and ankle, okay, that's your skill. I'm probably not going to assign, I will probably find a younger person for you to do this on. And the reason is because our nerves get stiffer as we get older. Okay. So if we have somebody there testing and they're in their 70s, and yes, that does happen. There's a whole agency out there called Seniors Helping Seniors. So there are senior citizens that get their CNA so that they can go help their other senior neighbors and friends and get paid for it. So yes, you may have somebody in the test that is 70 years old. Well, I'm probably not going to have you do range of motion on their hip, knee, and ankle because I know that they're probably a little bit stiffer. Okay, so I'm going to look for somebody younger. So let's pick on you two. Okay, so I might pick one of them, but she's got Converse high tops on and she's got just slip-on shoes. So she is going to be your patient for this skill. Do you guys see how they use every part of you to either include you as a patient for a skill set or exclude you as a patient for a skill set? Good. All right. So this care plan is only for this patient. That's it. Not for anybody else. This guy does not get range of motion. He's up and at him, moving on his own. He doesn't, just like you. You guys don't have anybody coming into your house to do range of motion on you, do you? Why? These are all good. You want to maintain your own level of ability, don't you? So why don't you have somebody coming in doing range of motion? You can do it yourselves. That's right. That's right. You're washing dishes. You're walking the dog. You're folding laundry. You're watering your plants. You're swimming. you're taking a walk, you are doing your own range of motion. You don't need anybody to help you. Either does he. Now, this patient, she does need some range of motion, but she goes to physical therapy twice a day, and they do range of motion on her non-affected extremities as well. This one, she needs range of motion to everything because she's bedbound. These are not the same patients. Good. Are you starting to see that every patient is going to be an individual and have individual needs? So we can't apply this to everybody and call it a day. It doesn't work that way. Good. So let's watch the video on this. This video takes like 2 minutes, maybe.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I need to do some exercises on your right hip, knee, and ankle. Is that okay?
Yes.
Okay, I'm going to close your curtain. Let me go wash my hands, and I'll be right back. Okay, after washing my hands, we're ready to get started. The first exercise I'm going to do is bring your knee up to your chest and back down to the bed. I'll do all the work. All you have to do is let me know if there's any pain or discomfort. We're going to provide 2 points of support, one under the knee and one under the heel. And we're going to lift up and all the way back to the bed. Feel okay?
Yes.
Any pain?
No.
We're going to do it again. Up and all the way back. And one more. Up and all the way back. Feel okay?
Yes.
Okay, now I'm going to work on the ankle. I'm going to lift your leg off the bed just a little bit, and then I'm going to bend your foot forward and back. You should feel a little stretch. Please let me know if there's any pain.
Okay.
So I'm going to lift under the ankle. We're going to bend the foot forward and then back. Feel okay?
Yes.
We're going to go forward and back. Feel okay?
Yes.
One more, forward and back. Good?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Are you comfortable?
Yes, ma'am.
Environment is clean. Bed is in the low position. Here's the call light. If you need anything at all, just press the red button and we'll be happy to come help. I'm going to open the curtain and go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. Okay, any questions on that? These really are the easiest skills there are to do. All right, we're moving on. Next skill is going to be denture care. You already know half of this skill. Denture care is mouth care with an extra step. So you already know half of this. You guys remember learning mouth care? Denture care is mouth care with an extra step. So a lot of students tell me this is the hardest skill for them to learn. It's a long skill. If you look down here, it'll take somebody with your level of experience about 13 minutes. So it's a little bit longer skill, but it's broken up into 2 parts. There's cleaning the dentures, and then there's cleaning the mouth the dentures came out of. So it's like a 2-part skill, and it requires a glove change in there. So students tell me that they kind of struggle with this one a little bit more than they do with other skills. Once you get it down, it's really not that hard. It just seems a little complex when you're learning it. Okay. All right. All right. Well, let me go back here real quick. So all of our principles are laid out here. Our skill-specific steps are here. We're going to go over these in detail. Down here is your test-specific information. Don't panic. They're going to give you 13 minutes to do this, but look who your patient is, a live testing student. Now, how are we going to do denture care on a live testing student? I'm going to explain that in just a moment. All right, so page 97 has our care plan at the top, step-by-step instructions here. We have all of our supplies here. And guys, there's a lot of supplies for this skill. You have to learn your supplies. Nobody's going to tell you, go get a barrier, a denture brush, a toothette, a cup of water, toothpaste, a towel, a washcloth, an emesis basin, and 2 sets of gloves. Nobody's going to tell you that. You have to know that. So flashcards are your friends here, but try to make it make sense to you, right? So what do you need to brush your own teeth? You need water, you need a place to spit, you need a toothbrush, and you need toothpaste. So you're already halfway there. You probably want to dry your mouth afterwards, so we're going to throw in a towel, right? So try to make it make sense to you. You already have those supplies locked in. So what would I need for the denture part? Let's add those in. And we're going to talk about each of those supplies in just a moment. So here's our care plan. It tells us a resident with dentures is sitting at an overbed table with the dentures in a denture cup. So where are the dentures? Are they in the mouth? No. So anybody can be sitting in this chair with dentures in a denture cup. That is how this can be done on a live testing student, because our care plan tells us dentures are not in their mouth. Now, here's something important that you need to understand. CNAs do not take dentures out. CNAs do not put dentures in. Not your job. Patients have to be able to do that themselves. If they can't, we puree their food. We chop it up really fine. But we do not put dentures in and we do not take them out. And let me explain why. When a patient has dentures and you try to remove them, those dentures are usually held in with denture paste. And now some of the newer dentures are actually, they snap onto posts that are embedded in the patient's mouth. So we have these dentures, however they're structured, embedded onto the gum in some way, either through sticky paste or through a snapping action. You've got to get those dentures out. So if you put your fingers in somebody's mouth, you have to be able to have leverage to pop that denture up because it's stuck to the gum. Good? Make sense? Now, if I'm doing that on myself, if I have dentures in my lower and I put my fingers in there and I pop those dentures up, I will never put enough pressure on my lower jaw to dislocate it. Like I would stop before I ever dislocated my jaw. But if I put my fingers in somebody else's mouth and I have to pop that denture up, these knuckles right here, this knuckle is going to press down while my fingertips push up, which means I'm pressing down on that jaw with enough force to unseat those dentures. And I have a very good likelihood of dislocating the patient's jaw. We do not take dentures out. We also don't put them in because when you put dentures in somebody's mouth, they will instinctively bite down to seat those dentures. And where are your fingers? Yeah, and they will bite you, and they will do it accidentally. I mean, it's a reflex. You put something, you're going to bite down to get those dentures seated. You aren't aware that somebody's fingers are in your mouth. Oops. So we don't take dentures out. We don't put dentures in. That is the patient's job. If they can't, no problem. We just don't use their dentures. We puree their food instead. It's safer for them and us that way. Good? Good. All right. It then says the resident's denture needs to be brushed with toothpaste and the resident needs mouth care. We're going to talk about this brush with toothpaste in just a moment. But our care plan is very specific in how we're going to deal with this patient's dentures. Not all dentures are dealt with the same way. It says the denture is stored in a denture cup after cleaning. So again, this is how we can have a live person sitting in this chair, because after we clean the dentures, are we putting them back in their mouth? No, we're putting them in a cup. So we have a live patient sitting in the chair while all of that's being done. But it does say the resident needs mouth care. So you will be brushing whatever that person has in their mouth using mouth care techniques. It says the resident's not able to provide their own mouth or denture care. I'm going to tell you that if somebody can brush their own teeth, they will brush their own teeth. They do not want you in their mouth if they can do it themselves. But this patient can't, so we're going to honor that and do a good job. We know all of these principles. There's nothing here to learn. We know how to read our care plan, how to do our opening. We're definitely going to need gloves for this. In fact, we need 2 sets of gloves for this, one for the dentures and one for the mouth. We're going to use a barrier. London rules are going to apply. We clean our basin the same way we clean all basins, and we finish up with the closing. Those never change. But let's look at our skill-specific steps here. So CNAs clean both dentures and the mouth those dentures came out of. And there's a couple of different types of dentures I want you to be aware of. Dentures are not kind of one-size-fits-all type thing. So when it comes to dentures, not sure what happened here. This is a full plate. Has a palate, has all of the teeth. We have pulled all of the patient's teeth and replaced every single one of them with a full plate of dentures. This is a top plate. I know it because there's a palate that fits over the roof of the mouth to hold them in place. A bottom plate looks different. It has a cutout for the tongue. It looks more like a horseshoe. But a full plate means the patient has none of their own natural teeth. But if somebody has some teeth that are still in pretty good shape, we're not going to pull the good ones. We're going to create something called a partial. Now, this is a bottom plate because it has a horseshoe shape. This partial replaces the teeth that are missing, that were pulled, but it has cutouts for teeth that remain. So this replaced all of the patient's teeth. This replaces just the teeth that are missing. Okay, so full plate and partial. Now we also have a little piece of a denture, something called a bridge. A lot of times now bridges are being implanted, so they don't actually come out. So over the next probably 20, 30 years, you'll probably see bridges disappear completely. I would imagine that partials will also kind of disappear over time because these are also being implanted at a much faster rate. And in fact, interestingly enough, I've been waiting for this, right, with all this genetics. What's the word I'm looking for? I just lost a word. See, don't get old. You lose words. Yeah, they engineer, well, not just engineer, but experiments. There's the word I was looking for, experiments. So with all the genetic experiments that are going on, I believe it was in Japan about 2 weeks ago, they announced that they developed the ability to regrow teeth for adults. Now, how amazing would that be? I can't imagine teething as an adult, but how amazing would it be if when your teeth wore out, we could just give you a little injection, you could grow a new tooth and you're good to go again. So that will be a really interesting development if it comes out to play. But in the meantime, we don't have that technology yet. So we have full plates, partials, and bridges, and we clean them all the same way. Okay, good. So there's 2 different ways to clean false teeth, dentures. The first way is the way our care plan told us to, and this is kind of the intuitive way. We get a wet toothbrush, we put some toothpaste on it, we scrub it up, just like you would brush your own teeth. This is what our care plan is telling us to do, this. But that's not the only way to clean dentures. And in fact, a lot of the people that make dentures will tell you that is not a good way to clean dentures, that for some dentures that are very, very susceptible to scratching because the material that they're made out of, we use denture tablets. So it really depends on the type of denture material that the dentures are made out of as to which method would be preferred. Good? Make sense? Okay, so what is this? Well, these are little fizzy tablets. You put the dentures in a denture cup, you fill it up with water, you put the little fizzy tablets in there, you let them soak overnight. And what the little bubbles in the tablets do is they get all up underneath that denture paste and it removes it from the dentures. We just rinse them off in the morning and give them back to our patients to be able to use. This is less abrasive. Toothpaste, very abrasive. Toothpaste actually has little things in it that scrub. Well, if we have material that's soft and we have scrubbing things on there, we can actually cause micro cracks to form inside the dentures, which harbor bacteria. It'll shorten the lifespan of the dentures, which is not what you want when it's a multi-$1,000 investment. Okay, good. This is not the right. I have one. I think I've got it at home. I have one where you can actually see the micro cracks that have formed. This one's in pretty good shape. All right, so to clean the dentures, we use a very specific tool called a denture brush. This is what a denture brush looks like. Denture brush has two sides. One side is big, looks like a toothbrush. We use it on the teeth. One side is tapered and narrow, and it is designed to fit in the channel of the dentures, the part that goes over the gums. This is too wide to clean that very well. This works much better in that area. Okay, good. All right. So when we're cleaning the dentures, we're going to wet our denture brush. We're going to put toothpaste on both sides. We're going to lay it in the basin just to hold it until we're ready to use it. Good. Same thing we did with mouth care. Same thing we did with mouth care. That denture brush can't be set down on anything. We've got to keep it clean. So we're not going to put it on our table. We're not going to put it on especially the side of the sink. That's not clean. So we have to have a clean place for our denture brush to hang out because we still got some work to do. We're not ready yet. We still have to turn that faucet on, and we have to protect our dentures, and we have to get our gloves on. So we don't want our denture brush laying on the side of the sink while we're doing all those things.
Are you supposed to actually place the paste on both ends at the same time? How do you stop it from falling off?
When you wet the toothbrush or the denture brush, and when you put the toothpaste on, don't put it on in a great big stripe. Just smear it on like you would do your own toothbrush. You want to smear it so it gets on those bristles. Okay. Yeah, it's the same thing. You know, when you bring your toothbrush up to your mouth, right, we want that toothpaste to stay on. So you've developed a technique to do this throughout your life. What's that? You balance? Yeah. You want to make sure that you just kind of get it on the bristles pretty well. Okay. Dentures cannot be set down anywhere. You can't put them in the sink. You can't, they either need to be in the denture cup or in your hand, or you can put them in that emesis basin if you need another place to put them, but you cannot set them on the side of the sink. Can't put them in the sink. You can't drop them on the floor. You want to protect those dentures. Okay. Good. Good. All right. Speaking of protecting the dentures, we also need to protect them if we drop them. So for this skill, we're going to put a washcloth in the bottom of the sink. And if we can get it over the drain, even better. Because when it goes over the drain, it actually lets the water pool up in the sink. So if we accidentally drop the dentures, and guys, dentures get really slippery. They've got saliva and food and denture paste and toothpaste and all kinds. They can get slippery. If those dentures should fall onto the surface of the sink, they can break. So we want a washcloth there. When the water goes on the washcloth, it gets wet, it gets softer, it breaks the fall. But if you can get that washcloth over the drain, that water will pool up in the sink a little bit. So now the dentures would never actually impact the bottom. They'd impact the water and then just slowly settle. Okay, so washcloth in the bottom. So we're going to protect the denture brush. Can't touch the sink. Can't touch anything. We want to use cool water for dentures, not hot water. There's a principle here, a scientific principle. Heat coagulates proteins. That probably doesn't mean much to you as a CNA. If you go into microbiology, it will mean a great deal to you. But heat coagulates proteins. What that means is there's a lot of protein on that denture brush or denture device. You've got saliva, which has proteins. You have denture paste, which has proteins. You have food particles, which have protein. Hello. You can go ahead and have a seat. You have denture particles, which have protein. Or, I'm sorry, food particles, which have protein. So it's important to understand that when we're cleaning dentures, we don't want to use hot water that's going to make all of those things stickier. We don't want them to actually adhere to the surface of our denture. Good. Cold water prevents that stickier thing from happening. So cold water. All right. So we're going to brush everything we see. The top, the bottom, the front, the back, the groove, the teeth, the palate. Basically, every part of this is going to get hit with our toothbrush. We should have toothpaste all over it. They're not timing you on how long that takes. It can take you 2 minutes. It can take you 45 seconds. As long as you get all of the entire denture covered with toothpaste, you're good. Now for the test, this is a real denture they're using. I'm going to pass this around in just a minute. This is a real denture. It's never been in anybody's mouth, but it's a real denture. Now, when you're taking the test, because it doesn't have denture paste on it, it doesn't have food particles on it, somebody else has already brushed it once in this testing center today. It's well cleaned. You don't have to sit there for a long time and scrub it because there's nothing to scrub off. But in a clinical setting, when you are really cleaning dentures, when you are really scrubbing these, do a good job. It may take you 2 minutes to get that denture paste off of there. Okay. Test is simulating. You're going to rinse all surfaces, keep the dentures over the sink, never over the floor. And we're going to fill the denture cup with cool water. We'll rinse it out, dump it out, fill it with cool water, put our dentures in it. Now, dentures must be stored in water, cool water. They should never be like this. They should never be in an empty cup because they will become brittle and break. Dentures are stored in water, not in a paper towel handed to the patient. They're put in a denture cup filled with water. Now, when we fill that denture cup with water and we cover it, that cup is going to be wet because we've just rinsed it and filled it. We don't want to put a wet cup on a wooden surface. If we do, it's going to warp the wood. So we put a paper towel underneath that surface to protect our furniture. Okay, good. So now we're done with the dentures. We took them out, we cleaned them, we rinsed our cup, we rinsed the dentures, we put the dentures in the cup, filled it with water, put a lid on, put a paper towel underneath, and we carried it to our patient's area. We're just going to put it on top of the table so they have access to it when it's mealtime. Now we're going to go back over, put our washcloth, wring it out really well, into dirty linen, and then we're going to grab our basin holding that denture brush and bring it back over to the table. We're all done with dentures now. Completely done with dentures, but we're not done with the skill because we still have to clean the mouth those dentures came out of. But do you think about all the things I've touched with those gloves. Think about all the things I've touched with those gloves. Do you want those gloves in your mouth? No, if you were the patient, you would want clean gloves. So once we get back over to the table, we get our basin on the table, we take our denture brush out and put it to the side. Now we're going to get rid of our denture gloves. We're done with denture care, get rid of the denture gloves. Now we're ready to start mouth care, but we're not going to put our new gloves on yet because we still have some prep work to do. We're going to put a towel over the patient's chest. We're going to get our toothbrush ready. We're going to wet it. We're going to put some toothpaste on it. We're going to put it in our basin. We're going to get ready for mouth care. And then we can put our gloves on and brush. And we're going to brush the same way we brushed for mouth care. Top, bottom, front, back, whatever they got, we're going to brush. Now remember, if your patient has full plates, top and bottom, they don't have any teeth. They just have gums. And that's fine. We'll brush the gums. But if they have a partial, that means they got real teeth in their mouth. And that's fine. We'll brush the gums and the teeth. We're going to brush whatever is in there. But in most cases, we're going to use a very special type of item to do that cleaning, and that's called a toothet or an oral swab. This is a soft, spongy, four-sided sponge. And I'm going to explain to you why this is better to use than this. Okay, let me pass all this around so you guys can take a look at it while I'm talking. Actually, let me just do this. This will be quicker. So you can take a look at all of those supplies. All right, so a toothet is preferred when our patient has dentures. First of all, it's very soft on gums, non-abrasive. But the real benefit to this is it has four sides. A toothbrush has one. There's denture paste in your patient's mouth. If you use a toothbrush and you brush denture paste, that paste is going to get all wound up in those bristles. And what that means, because your toothbrush is all gunked up with denture paste, is by the time you get done with one part of the gums, your toothbrush is pretty much ineffective for the rest of the mouth. This, we can swipe, roll it a quarter turn, swipe, roll it a quarter turn, swipe, roll it a quarter turn, and swipe. And if it gets all gunked up, we can throw it away and get a new one. Okay, good. So when you're working with dentures specifically, this is better for cleaning techniques than a toothbrush. Now, that doesn't mean that you can't use a toothbrush. If you want to use a toothbrush on the patient's teeth, go for it. But that toothbrush is probably going to get all gummed up with the denture paste. So rinse it frequently. So we're going to do mouth care like we did mouth care before. We're going to dunk our brush, in this case, the toothet, in water. We're going to apply some toothpaste. We're going to put it in our basin while we get our towel and gloves on, and then we can brush whatever they have. Perform mouth care. That's the whole checklist, guys. Provide mouth care. You know how to do this. It's one checkpoint. Just provide mouth care. It doesn't say to brush for 2 whole minutes, does it? No, it just says provide mouth care. Okay. Let them rinse as much as they need to. Let them spit. Give them something to spit in. Make sure that when they're spitting, you're holding that basin in an area that they can reach. One of the evaluators reached out to me recently and she said, can you make sure that you are stressing this? Because she's seeing a lot of testing students that don't hold the basin here. They hold it out here. Can you imagine trying to, get out to that basin to spit in it? Make sure it's close enough for your patient to actually use it effectively. And then, of course, dry their face. We talked about this. This is a very frequently missed step, drying their face. We'll dispose of our soiled linens. We're going to clean our basin the way we clean everything else and store it. All of those steps are the same between mouth care and this. A question I get asked a lot at this point is, Do I have to clean the dentures first? Can I clean the mouth first? And the answer is the checklist doesn't care. There's nothing on there that says you have to clean dentures first or you have to clean mouth last. There's nothing that indicates order. But time management is an issue. You're going to have way more to do than you can possibly get done in your shift. You are going to be racing the clock. It's just a fact of life. So you want to get these skills down to the point that you can perform them very quickly, but also you want to make sure that you're performing the skills in the shortest version possible for your own time management. And this is one of those areas that you can kind of shave off a couple of minutes. If you do mouth care first, that patient has to spit in that basin. Well, we need that basin to hold the denture brush. So that means we have to go to the sink and we have to clean the basin before we can get to dentures. Now, if you do it the other way, if you do denture care first, that basin just held the denture brush. It doesn't have any liquid in it. So then the patient can spit in it and you only have to clean it once at the end. So you can do this in either order. Just remember, if you do, it requires another basin cleaning, which is more time. Good? We're going to use all of these principles to check off our checklist. This is the checklist from the state exam. So let's figure out how we're going to get 100%. Well, first, we're going to follow our care plan. Then we're going to do our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to clean your dentures. Is that okay? Close curtain, wash hands, get supplies. We're going to put a barrier on our table, and we're going to decide if we need gloves. Well, this skill, we're working with body fluids, both with the dentures and with mouth care, so we need 2 sets of gloves. We're going to get a barrier to put everything on. We're going to follow our linen rules. When we get our towel and washcloth, don't hold them against our uniform. Nothing goes on the floor. Dispose of your linens when you're done with them. All of those rules still apply. We're going to clean our basin the way we clean all basins, rinse it, dry it, store it. We're going to do our denture care steps. Now, this is a lot of this skill. So remember, some of them we see that very, very, very little black skill specific steps. This one, half of your skill is skill specific. And that's really what makes this hard for students, because every single one of these steps really does count kind of big. Okay. This is one you really do need to practice. Now, when you're practicing in here, remember, I'm going to try to give you some practice time today. You won't have a lot today. On Wednesday, you'll have a little bit more. Next week, you'll have a little bit more built into class time. And then the week after graduation, you have Monday and Wednesday from 9 to 1 that you can come in and practice. And we have dentures for you to practice with. We have mannequins. We have other students, whoever's in here practicing. But at home, if you don't come in here to practice, you need to practice somewhere. And that means that you're going to need some dentures to practice with. Now, most of you probably don't have a set of dentures laying around that you can just pick up and practice with. So our practice kit, the ones up there, actually come with dentures. They're fake dentures. You cannot really use them. They will not fit in anybody's mouth. They're made out of, my mom makes these for me. Okay. They're made out of resin, but they do have a channel, just like dentures do. So it gives you the same experience of cleaning dentures as if you came in here and practice. So if you're going to come in here and practice, this is one I would definitely tell you to practice because you've got everything you need here. But if you're practicing anywhere else, I would highly recommend that you get that practice kit so that you have the dentures and the denture brush and the toothette and the toothbrush and everything you need to practice. Good? Good. All right. So once we've got our skill-specific steps, then we're going to do our closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Bed's in low position. Environment is clean. She's not covered because she's sitting in a chair, remember. But here's your call light. Open the curtain. Go wash my hands. Think about my steps. Make any corrections. And then tell the evaluator my skill is done. Now, this care plan is only for this patient. This one has all of her own teeth. She doesn't need denture care. This one has dentures, but we use those fizzy tablets. And we do her denture care. So her care plan is completely different. She has dentures, just like this one, but we care for them differently. This patient also has dentures, but he takes care of his own. So it's not even on our care plan. Remember that every patient will have a different care plan based on the needs of that patient. Questions? So let me show you the video for this one. The video for this is a little bit longer because there's a lot of steps to this. And this is why I'm trying to get through today pretty quickly so that we can give you the practice time to be able to practice all of these skills. We're at that point now. Yay. Isn't that exciting?
Hello.
Good afternoon, Mr. Jones. How are you?
I'm well. How are you?
Wonderful. My name is Patty. I'm your CNA today, and I would like to help take care of your dentures and perform mouth care. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. I'm going to take your dentures to the sink to clean them.
Okay.
I'll bring the denture cup to the sink on the paper towel. We're going to set it on the side of the sink and open it, placing the lid beside it, and then wash my hands. After washing my hands, I'll get my supplies. We're going to start with a barrier. This is going to provide a clean place to put our clean supplies. So we'll spread the barrier out on the table with the absorbent side facing up. And for this skill, I'll need a towel and a washcloth, being careful not to let the supplies touch my uniform. I'm just going to go gather the rest of your supplies. I need a toothette, a denture brush, and toothpaste, along with an emesis basin and a cup of water. We'll set these on the overbed table. And I need 2 sets of gloves. Okay, I'm going to get the denture brush ready. We're going to wet it and apply just a little bit of toothpaste on both sides. Set it in the emesis basin right now. I'm going to take the washcloth, a set of gloves, and the emesis basin holding the denture brush to the sink. Mr. Jones, I'll be right back. I'm ready to clean the dentures, so I'll set the prepared denture brush in the emesis basin on the side of the sink. I'm going to place the washcloth in the bottom of the sink over the drain and put my gloves on. I'll take a paper towel and turn cold water only on because we only wash dentures with cold water, and we're going to throw that paper towel away. Now I can clean the dentures. I'm going to take them out of the denture cup and rinse them off, making sure that I hold them over the sink at all times. I'll take the denture brush, and the small end of the denture brush is going to clean the groove part of the dentures. So we're going to clean that whole groove, all areas, and the palate. Then we'll turn the dentures over, being careful to hold them securely, and use the other side of the denture brush to clean the teeth part of the dentures. We want to make sure that we cover all surfaces. Making sure that we hold it securely. And then we can rinse the denture brush and put it back in the emesis basin for later use. We're going to rinse the dentures off, removing all of the toothpaste. We'll take the denture cup, dispose of the water, rinse it out, and fill it with cool, clean water, placing the dentures inside, cover it with a lid. We can throw this away and get a clean paper towel to place underneath it. I can turn the faucet off, and we're going to go put this on the patient's bedside table. I'll place this denture cup on your bedside table over here for use later. Now I can remove the washcloth and place it in dirty linen. Now I'll bring the emesis basin holding the denture brush over to the overbed table and take the denture brush out and set it aside. Now I can remove my gloves. I'll throw these gloves away. Mr. Jones, I'd like to place this towel over your chest while I perform the mouth care portion of this skill. Is that okay?
Yes.
I'll get the toothette ready. We're going to get it wet. Put a little bit of toothpaste on it. And then hold it in the emesis basin while I put my gloves on. Okay, Mr. Jones, I'm going to brush all areas of your mouth, the top, the bottom, the front, the back. So I need you to open up wide for me, please. I'm going to start in the back, on the top, both sides, and then the bottom in the back, the front, and can you bring your teeth together? Thank you. Okay, thank you very much, and we'll rinse. Okay, pour the rest of the water in there. And just make sure that your mouth is nice and dry. Okay, I'm going to place this in dirty linen, clean my basin, and then clean my work environment. I'll be right back. We'll take the basin to the sink and dispose of the contents into the sink. We'll then rinse the basin and set the basin down in the sink. We'll use a paper towel to pick it up, a paper towel to dry the inside, a paper towel to dry the outside, and then one more for the drawer. On the way to the drawer, we'll pick up the denture brush and the toothpaste, placing them in the emesis basin for storage. The supplies away, we'll use a paper towel to open the drawer. We're going to put the basin, toothpaste, and denture brush in the drawer, and then close it with the paper towels, and we can then throw the paper towels away. And now I'll dispose of all of my disposables. The cup, the wrapper, and the toothette, along with the barrier. These will go in trash. Now I can remove my gloves. We'll throw the gloves away. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Your environment is clean, your bed is in a low position, and you're safe. Let me give you your call light.
Okay.
Here's your call light. If you should need anything at all, just press that red button and we'll be happy to come back and help. I'm going to go open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done. All right, we had a comment. I know you're supposed to wash your hands and scrub for 20 seconds, but what happens if you pass the 20-second mark? Nothing. It's perfectly okay to wash longer than 20. It's a minimum of 20 seconds. But where do those evaluators want to be? Home, in their pool, drinking their margaritas. If you're standing there washing your hands for 3 minutes, doing a surgical scrub, they know you have no idea what you're doing. You have no, because in a clinical setting, you are not going to stand at a sink and wash your hands for 3 minutes before and after every single patient. That's unrealistic. That's a surgical scrub. That is not what we do. So over 20 seconds is okay. There's nothing wrong with 25, even 30 seconds. But if you're just standing there scrubbing for minutes, those evaluators are going to get really irritated with you because you're the one keeping them from being at home where they want to be. Okay? Good? Questions?
It's just the tube that's disposable.
Right, right. The denture brush will be used over and over. Yeah. Yeah. So this is the practice kit I was telling you about. It has everything that you need to practice, including dentures. I don't have the dentures on here right now, but including the dentures. It has a bedpan, which we're going to get to next week, the Gait Belt, which we're going to get to right now, all of the basins, food tray, graduate container, a drainage bag, a whole bunch of gloves, emery boards, orange sticks, toothbrushes, toothlets, denture brush, chucks. Everything you need to practice is in that kit. And when you guys are in class up through graduation, you get a discount on it. I don't give them discounts. All right, so now we're going to get to Ambulate with a Gait Belt. So this is on page 66 of your book. Okay, so if you look at page 66, coming down the side here, you can see all of the principles involved. They're all spelled out for us here. These are the skill-specific steps we're going to go over in just a moment. And then down here, this is our test information. So somebody with your level of experience should be able to do this skill in 5 minutes or less. Way more time than you actually need. I'll explain that when we read the care plan. This is going to be done on another live testing student. That person will start out in a chair. This is not a documentation skill. If you go to page 67, we have our step-by-step instructions, our care plan at the top, and our supplies at the bottom. So let's take a look at this care plan. Care plan says ambulate the resident at least 10 steps. How far are we walking them? Yeah, that's 5 steps in one direction, turn around, and 5 steps back. We're not walking them very far, and they gave us 5 minutes to do that. 5 steps in one direction, 5 steps back. 5 minutes. Way more time than we need. Now, we have to put an opening in front. We have to put a closing behind. We're going to put a gait belt on, which takes about 10 seconds. But still way more time than we need, so don't rush your patient for this. Okay? It says use a gait belt or transfer belt. Should we use a walker? Why? Care plan says gait belt or transfer belt. We don't change this. Patient will be sitting in a chair at the side of the bed with shoes on. They've already done this for you. Yay. So they're giving us 5 minutes. We don't even have to put shoes on. Cool. Says patient is able to walk but needs assistance to stand. So in order to understand this, we've got to talk about a couple of concepts here. So I've got a lot of teaching to go over with you before we get to this skill. And then after this skill, we'll take our break. Okay. Got a couple things I got to explain to you to get this done. One of the first things that we have to learn is shoe rules. Now, this is our very last principle. Looking on the back wall, we know everything on that back wall except for this. So we're going to focus on this right now. It's our very last principle. In order to understand shoe rules, though, we have to kind of backtrack and learn something else. So if you go to page 63, I'm going to explain to you about energy conservation. How many of you guys have ever seen an older person try to get out of a chair? You ever see an old person try to stand up that's weak? Okay, there's an inverse relationship between strength and effort that I'm going to explain in just a minute. But when you see an old person try to get up out of a chair that's weak, this is what it looks like. No. How much effort did that take? Took a lot more energy to do that than it would have to just stand up, right? Make sense? Okay. So what we have to understand is that there are changes in our lifespan that are going to affect how our ability level is. And this is one of those changes. So there's an inverse relationship between strength and effort. What that means is if it takes more strength than I have, if I have too little strength, that means I'm going to have to put in a lot more energy to get the job done. If it takes less energy, or if I want it to take less energy, I have to have more strength. Good. There's an inverse. Think of it like a seesaw. Now, when we're older, this is a problem because we're out of both strength and energy. And this is where gait belts come in. Because by using a gait belt, I can lend them some of my strength. That's all a gait belt is it's the ability to let somebody borrow some of my strength. Now, there's another problem with this whole scenario that I need to explain to you. And this is more psychological, okay? Have you ever seen a 2 or 3-year-old? Anybody have a 2 or 3-year-old running around? Oh, my favorite age. I love 2 and 3-year-olds. Love them. Now, they can be challenging. And one of the reasons they're challenging is we call it the terrible twos, right? They have temper tantrums. They say no to everything. They're contrary. But that's actually a hugely important stage of development because that's when they realize that they are not a part of you. They are separate. And they start to employ some of their own autonomy. So when they tell you no, that's actually a good thing. They're learning how to set their own boundaries, how to work within themselves, how to dictate their own identity separate from others. It's a great thing. What you have to do is channel that. And limited choices are your best friends when you're working with 2 and 3-year-olds, by the way. Don't say, do you want to brush your teeth now before bed? No, we don't say that. Would you like to read your book first or brush your teeth first? Limited choices, just like we did with dementia patients. Limited choices. That way it still allows them some control, some ability to dictate their own way of moving through life, but it also makes sure we're getting things done because otherwise no will be the word of the day. Okay, so 2 and 3-year-olds, awesome creatures. They also will jump up and down for no reason, none at all. They don't need a reason to jump up and down. They have excess energy and they just bounce. When was the last time you bounced, jumped up and down for no reason? Probably when you were 2 or 3. Now, if I win the lottery, I'm jumping up and down. Absolutely. I've got a reason though. But just for excess energy, no, we lose that somewhere around here. And that's because our energy levels actually peak here. It's downhill from there. And I'm going to prove it to you. Let's go out 10 years. Let's talk about a 12-year-old. 12-year-olds still have tons of energy. Man, they can skateboard, they can play basketball, they can video game, tons and tons of energy. But you put that 12-year-old in charge of that 2-year-old for one afternoon, who wins? 2-year-old every day, every time. That 12-year-old will say, Mom, can't they go down for a nap? I'm tired. You have lost energy in that time span. We don't think about it that way, but this is real. Now let's go out to 22. 22-year-olds still have tons of energy. They can go out, shop till they drop, go out at night looking fabulous, right? Still tons of energy, but they do not have the energy level they had when they were 12. Let's go out to 42. 42, we're shopping till we drop, but that's at like 3 and we're not going out tonight. Okay, we have condensed our energy. Let's go out to 62. 62, we're putting our feet up for 10 minutes before we make our dinner because we ran out of energy. We've got to recharge a little bit. We're thinking about retirement because there's just not enough energy to get through our daily routines that we need to do along with a full-time job. So we're slowing down. Our energy levels have decreased. What do you think that energy level is going to be like at 82? Now, I just told you that there's an inverse relationship between energy and strength. We've already lost strength just by being older. And now we've lost energy. So we're both down here, which means things probably aren't going to get done. You're going to go to your patient and say, Mr. McGillicuddy, would you like a shower? And he's going to say, no, I don't have the energy. Let me explain something to you real quick. Let's go to here. 22. This 2-year-old bouncing up and down saying, come play with me, come play with me, come play with me, come play. You look how much energy you got. It's a lot of energy. But when that 2-year-old says, come play with me, what do you say? I don't have the energy for that. Oh, you got plenty of energy. You just don't have that kind of energy, right? Can you get this guy to understand that you don't have their energy? You're talking in the wind. They do not get it. They think everybody has their energy. Well, why wouldn't they? That's what they've got. They consider everybody to have their energy. Let's go back out to here for a second. This person is trying to tell you that they don't have your energy. Do you think you get it? You don't. You are the 3-year-old in this situation. You are the 3-year-old in this situation. Your older patient is going to say, I don't have the energy for that. And you're going to go, what energy? I'm doing all the work. All you got to do is sit there. What do you mean you don't have the energy? You are literally trying to explain, like that 3-year-old tried to explain to you, that of course you have the energy to play with me. You guys see this? It's important that you understand this because your older patient is not at the same energy level than you are. Not even close. And yet you will try to convince them that they are. Sure, I can give you a shower. All you got to do is sit there. I'll do all the work. All you have to do is sit there. If they don't have the energy, they don't have the energy. And we have to understand that. But there are some things that we can do to help them conserve energy. So when it comes to shower time, they got enough to get through. And that's what we're going to talk about today is energy conservation. When it comes to energy conservation, if we're going to conserve energy, we kind of have to think about the things that take energy on a daily basis. So let's look at that. These are all things that you need to do every day, right? You got to get up. That takes half of my energy every day, getting out of bed. Yeah, half of my energy gone because my bed is comfy and I like it there. It takes a lot for me to get out. So we got to get up. We've got to do some grooming. We got to do some bathing. We got to do some dressing. We got to walk to places. We got to eat. We have to talk to other people. We got to clean. We got to go to the bathroom. We got to do a whole lot of things just to get through the day, just to get through. Now, if you wonder if something takes energy, the best way to figure it out is to ask yourself, have I ever been too tired to do that? Have you ever been too tired to eat? Absolutely. I have been too tired to eat, and you probably have too sometime in your life. Well, if you've ever been too tired to eat, that means eating takes energy. Have you ever been too tired to talk? Mondays and Wednesdays when I get home, because I've talked for 4 hours straight here. When I get home, I need a couple hours of quiet time. I don't want to talk. My voice is shot because I've talked nonstop for 4 hours. So I have, on a regular basis, been way too tired to talk. My husband thankfully understands, and he leaves me alone for a couple hours. Okay. Have you ever been too tired to walk? Like getting from the couch to the bed seems like a monumental journey. Okay. If you've ever been too tired to, that thing takes energy. Now, remember, our older patients have this much energy. This is it. This is all they got. They can't go to the store and buy anymore, no matter what 5-hour energy tells you. There is no more. This is it. And if they've got to get all of these things done, there's a possibility that there may not be enough energy to get all of those things done, which means that when you go in and say, hey, I need to brush your teeth, they may say, no, I don't have the energy. We have to be considerate of that, okay? But we also have some things that we can do to ensure that they have enough energy so we can get our daily things done. And part of that has to do with taking steps to conserve their energy by giving them some of our strength. Now, another topic that we have to talk about is diabetes. And this is a very, 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 very watered down 5th grade version of diabetes. Understand that there are people that make their living learning about diabetes, doctorate degrees. I'm not giving you that. This is super watered down. Every cell in your body needs food. Every cell needs to be fed. Its fuel of choice are carbs or sugar. Carbs break down into sugar. Carbs get a bad rap in our community, our society. Carbs are not bad. Carbs are the most abundant source of fuel for every cell in your body. Carbs are not bad. Carbs in excess are bad. And our diet is mainly made up of carbs. That's why our society gets a little down on carbs, but carbs themselves are not bad. What happens in the body is that you eat a carb. A carbohydrate would be like bread, rice, pasta, anything white. So flour, anything made with flour. Sugar, anything made with sugar. Okay. There's, we call it the rule of white. There's very few white things that are not a carb. When you eat that carb in your body, it breaks down into sugar. The body actually pulls it apart and creates sugar molecules out of that carbohydrate, sugar and water. Now, when that happens, your brain says, hey, we got some sugar. We want to get that sugar into the cell. But do you notice the cell has a door that's locked? So the brain says, we got some sugar. I want to get it in the cells. So what I need are some keys. So it tells our onboard key factory called the pancreas, hey, throw me some keys. So the pancreas makes some insulin, keys. Those keys go into the bloodstream. They unlock the cell, and then the carbs or the sugar can enter that cell, and the cell is now happy and fueled up and ready to go about its day's business. This is a healthy system. This is what it looks like. You eat carbs, they break down into sugar. Our pancreas produces keys. The key then opens the door and allows that sugar to enter the cell. That is the way a healthy metabolism works. Now, when we have diabetes, that system is exactly the same. Nothing has changed, except that we can't unlock the door. We eat carbs, they break down into sugar. The cell is starving, still starving, still starving, Still starving because we don't have any way to open the door. So all of that sugar, instead of being in the cells where it needs to be, stays in the bloodstream, and we call that high blood sugar. Good? Good? Okay. Remember, 5th grade version. All right, so what does high blood sugar do? Why should we care? Well, inside your arteries in the body, when we have all kinds of stuff, we got some liquid in there, we got some red blood cells, we got some white blood cells, we got some platelets, we got all kinds of stuff floating through that blood. Now, when you add sugar in, it kind of rocks the boat a little bit because sugar is not a plump, round, slippery kind of cell. Sugar is a crystal. Kind of looks like this. Jagged. This is not a cell. Cell is smooth, round, slips in and out all kinds of places. This is not that. This is hard and jagged. Now, when we have excess blood sugar in the artery system, that crystal, okay, is going to coat the insides of the arteries. It's going to make them stiff so they can't expand, they can't contract. They're very stiff. But because they're jagged, they're going to catch everything that floats by. All those nice, smooth, round cells, it shreds them. So it shreds their red blood cells. It shreds their white blood cells. Now, white blood cells are important for healing. Red blood cells are important for oxygen transport. And platelets are important to coagulate. So if we get a cut, what stops the bleeding is platelets. Now, if we have in our arteries a whole bunch of sugar that's shredding these cells, then we're probably not going to get enough oxygen where it needs to go. We probably are going to have problems healing because our white blood cell count is a little bit low. We're probably going to have a hard time clotting because we're missing some platelets. Now, there's one more piece of this puzzle, and that's cholesterol. Cholesterol in your arteries looks like pizza cheese. That's really, I mean, if you cut open an artery, that's what it looks like, is a big glob of pizza cheese. Now, you can imagine how much pizza cheese could get all wrapped up in this, right? That's not a good day. So all of that gunk is going to clog up the arteries, and this is what that looks like. We have a brand new newborn artery. This is a beautiful artery. I wish mine looked like that. They don't. After a couple of years of occasionally overeating, having some excess sugar in our bloodstream, they start to get more like this. This is thicker. See how this one's more wide open? This is smaller opening because the walls are thicker. Now, this is probably in our late teens, early 20s, and we still eat pizza. We haven't worked in those salads all that much yet. When we get into our 30s and 40s, it looks more like this. That's your pizza cheese. That's binding up all of the cells. Now, this is pre-diabetes. Our body's saying, hey, we got to make some changes. And if we don't, we end up with this. Now, this is our arteries are almost totally occluded. And this red thing in there, that is a blood clot. Because when blood slows down or stops, it clots. Blood can't go through this. It's too restricted. So it has slowed down and then it has clotted. Now, when this happens in the arteries around the heart, because they're super, super teeny tiny, when this happens in those arteries, we call it a heart attack. When this happens in the arteries in our head, we call it a stroke. So our diabetic patients are at risk for heart attacks and strokes. Good? But there's two places that this has a profound impact. And that's all because of gravity. Gravity on planet Earth. This is a crystal. It's heavy. Gravity is going to pull that down. So those crystals are going to end up down here in our feet, occluding all of those arteries, which means we're not going to get good blood flow to our feet. It's also going to affect our hands, the lowest points of our upper body. So our hands and our feet are going to have the most effects from diabetes. Hand care, foot care. That's why we do those skills, is because of this. Now, when we have an occlusion, when our feet don't get enough blood and we don't have the ability to feel very well because of something called neuropathy, which is this, we can get injuries on our feet and not even realize they're there. Somebody can step on a thumbtack. If you stepped on a thumbtack, you would hop around on one foot, go ow, 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 ow. It hurts, it hurts. But if somebody has neuropathy and they step on a thumbtack, they will not know it's there. They will have no idea. The foot knows there's a thumbtack there. The foot's like, hey, brain, we got a problem here. And the signal is trying to go through lines that are coated in sugar. This transmission is not getting from point A to point B. It got stopped on the way. Foot knows there's a problem, brain does not. Now, we understand that as we get older, we get less bendy. Right now, you guys could all probably look at the bottom of your foot if you needed to. Later in life, that's going to get harder. At some point, you're not going to be able to look at the bottom of your foot. So if you can't look at your feet and you don't have good feeling in your feet, that means we can have an injury that we don't even know is there. That is why foot care exists. But it's also why one of our rules is that your patient needs to wear shoes. They must wear shoes. Now, I know, I get it. If you go to any hospital, standard issue is a gown and a pair of slipper socks. And we get so excited about these things, we take them home, right? Free socks, yay. Yeah, these do not protect against injury. They barely protect against slips. They're better than bare feet, but marginally. Shoes, way better than both. So if your patient's out of bed, they need to have shoes on. If the patient doesn't have shoes, who should we tell? The nurse, absolutely. But there's no excuse for walking a patient through a setting without shoes. Now, let me show you something that's really gross. Anybody ever been a patient at a hospital? Anybody? Nobody? Never? Okay. So when you were in the hospital, they put you in a gown, they gave you these socks, you laid down, but at some point you had to go pee. So you swung your legs out, you walked to the bathroom, you did your stuff, you come back to the bed, and you get back into bed. You did not put shoes on. You walked through that. You walked into, how many of you guys would walk barefoot in a Walmart bathroom? Those are Walmart germs. Those aren't even the big bad germs. Those are just Walmart germs. And yet you are walking in hospital germs. You guys remember us talking about hospital germs? Way bigger, way badder than Walmart germs. You have walked through those and then, yeah, it's all the way in the back on the right. And then you got back into bed with those germs still on your socks. Now, as you toss and turn in that bed, those germs move up. And if you've got any incisions, they're going to find them because incisions are warm, dark, and moist. Slipper socks are not enough. Not enough. They don't protect against injury, and they certainly don't do anything for infection control. Good? All right, let's talk about gait belts. So a gait belt is a flat canvas belt, has a buckle on one end, the other end is the free end, and it has a tag. Like every other article of clothing, the tag goes inside. Easy. It does not matter whether the buckle faces this way or the buckle faces this way. Nobody cares. But you put this around the patient's waist. Now I'm going to put it around mine just to show you. But this goes around the patient's waist. And when you put this around the patient's waist, you want to put it around so that it's not twisted. It's flat. Okay? So it's flat, not twisted. Flat. Now, once you have it around the patient's waist, all right, Jake, we're going to need to zoom in. Once you have it around the patient's waist, not yours, I'm just demonstrating. Once you have it around the patient's waist, you put it through the first end, put it where you can see it, first end by the alligator teeth. Jake, a little closer maybe. There we go. Okay, see these alligator teeth? We want to put it through the first guard by the alligator teeth, and we're going to pull the direction those teeth point to get it snug. Now, we want this snug because if it's too loose, when you go to lift the patient, it'll go under their breasts or under their arms, or they'll slide right out of it. So you want it tight enough, it's going to stay. So we're going to tighten it up. And then once it's tight, we're going to put 4 fingers underneath the belt, between the belt and the patient, 4 fingers flat. You should be able to fit 4 fingers. If not, it's too tight. But if it's like this, if you can fit 4 fingers and everything else, it's too loose. It's going to come off the patient. So snug it up, 4 fingers, and then we want to lock it in place. So we take that end, put it through the second guard to lock it into place. Now we got this free tail that's hanging down. It's probably going to be in your way, so you can just tuck it in the belt. Can't see. Tuck it in the belt to get it out of the way. Now, when we go to take off a gait belt, we take it out of the second guard, and then we hold this. When we put it on, we pulled this and held the buckle. To take it off, we hold this and slide the buckle. Okay, so on, we hold the buckle, pull the tail. Off, we hold the tail, slide the buckle. Yeah, except it wants to make a liar out of me today. There we go, slide the buckle. Okay, good. Don't, when you take this off, don't slide it against the skin. Listen, that sound can cause a burn, an abrasion. So we don't slide it, we just loop it over, or we reach around and grab both ends. Okay, good. All right, Jake, thank you. All right, so once we get the gait belt in place, we're going to make sure our patient's feet are flat on the floor before we stand them. Now, this is a problem for me because I've got very short legs. When I'm sitting in this chair, my feet are not flat on the floor. I actually have to scoot my butt forward a little bit to get my feet flat on the floor. Make sure your patient's feet are flat on the floor before you stand them. We're going to count to 3, 1, 2, 3 before we stand. We make our patient our partner. They're not there for us to do things to. They're there to do things with. There's a big difference there, so we're going to count to 3. Once we get them standing, we're going to ask, are they dizzy? You feeling okay? Everything good? I want to find out here at the chair, not down there. If you're walking somebody and they start to get a little wonky on you, they put their hand out to the wall, they start to lean, they put their hand here or here, they slow down, they get pale or sweaty. Patients give you all kinds of clues that something is going very wrong. Pay attention to those clues. But what you do next is going to determine whether that patient's going to fall or not. 90% of you will want to rush that patient right back to that chair. They start to look a little squirrely. You try to get them to safety. Rush it. They aren't tolerating a slow walk. What makes you think they're going to tolerate a rush back to a chair? They're not going to they're going to fall. And then your conversation with the nurse is going to be, well, I saw that they were not looking right, so I got them back to the chair, but they didn't make it and they fell. Well, yeah, we don't want to try to get them back to the chair. They're not going to make it. Instead, sit them down wherever they are. Get them safely on the floor, because a patient that's sitting on the floor cannot fall on the floor. Get them into a safe position and then send somebody for the nurse. We don't leave patients in distress alone. So we call for a staff member. We grab a housekeeper that's walking by. We ask another patient, can you go get the nurse for me? We stay with the patient and we get a nurse to assess them. But if you try to get them back to the chair, they're probably not going to make it. And the fall is what's going to hurt them. Good? But I want to find out at the chair whether we're dizzy, not down the hall. That patient should be your total source of attention. Not the phone, not somebody that you're talking to, not the TV at the end of the hallway, that patient, because you'll miss the clues they're giving you if you're not paying attention to them. Now, when we go to sit a patient, we want to back them up so that they can feel that chair behind them before we help them sit. Don't ever ask a patient to trust that there's a chair behind them. They're not going to. They'll stiffen up. They'll get like this, and you're trying to sit them down, and they're like boards. They need to feel that chair behind their legs. And then we're going to stand in an oblique angle. So we don't stand right in front of a patient to stand them up or sit them down. That actually pulls you off balance. You want to stand at an oblique angle, which is 1 foot in front of their feet, 1 foot parallel to the chair. You're going to bend at the knees, not the waist. All right, that's body mechanics. Please remove any obstacles before you stand to walk the patient. And this is kind of important because if you stand somebody up, let's say that I stood somebody up and I'm going to walk them to that this stand is in my way. I would have to maneuver a patient around that stand or leave my patient standing to go move the stand. And either one of those is not safe for my patient. So before I ever stood that patient up to walk them, I would move that out of my path. Good. Okay. All right. So now we know all the principles. Let's look at our skill-specific steps. And a lot of these are repeats of what we just learned. But we're going to put the gait belt over the patient's clothing. I don't know. I honestly, I don't know why this is even a checkpoint. I don't know who's out there putting the gait belts on under the patient's clothing. I don't know, but it is a checkpoint. So over the clothing, please. We're going to hold the gait belt on the side to the back. Don't hold the gait belt in the front and pull the patient like this. That gets them off balance. You want to hold at the sides or at the back. And remember, we're giving them some of our strength. So we're helping them to stand. That way their leg muscles don't have to do as much work. You want their hands on your shoulders when you lift them. If their hands are at their sides like this, do you see how their shoulders are trailing backwards? This puts your patient off balance and they're likely to fall, but it also puts more pressure on your back. So you want their hands to just rest on, not around your neck, just rest on your shoulders so they move as a unit. So everything moves together. Now, when you're walking a patient, they should be slightly in front of you and to one side. You're going to hold on to the gait belt in the back, underhand grip. That way, if they start to go down, you've got that gait belt. If you're holding like this and they start to go down, it'll slip right out of your hand. So underneath, you want that patient to be your total focus as you're walking them. Ask them throughout the skill, how we doing? You dizzy at all? Everything going okay? And then we're going to help them sit using that gait belt. Same oblique stance. You're going to remove the gait belt. Don't pull it against their body. And then make sure they're seated properly at the end. That's the whole skill. That's it. So our care plan, we read it. It tells us to walk the patient at least 10 steps. For the test, they're going to give you a destination. Like if we were testing in this room and I've got a chair, it would not be a chair on wheels. But let's say that I have a chair here. And I give this skill to you. You're going to walk this patient at least 10 steps. I'm going to tell you, go to the door and back. So they actually give you a destination where you're not having to maneuver around stuff. Okay? Good? Good? All right. 5 steps in one direction, turn around, 5 steps back. If you're the patient for this, you are going to walk like you walk. Do not turn into a 90-year-old invalid. Don't start doing something like this. Okay, that's not what we're trying to do here. Walk like you walk. Don't make this any harder for the person testing. All right, so let's see how we're going to check off this checklist. We're going to follow our care plan. We're going to do our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. Would you like to go for a little walk? Feel okay? All right, let me go close your curtain, wash my hands, get my supplies. I'll be right back. Yes, you should close the curtain for this. I get that question a lot. You should. Because if that patient is just wearing a hospital gown, we need to get another gown on as a robe. We don't need full moon over Spring Hill, okay? So close the privacy curtain until you find out what you're working with here. We're going to assess whether we need gloves. For this skill, you probably won't because your patient's fully dressed, holding onto all of their body fluids like a champ for the test. It's another testing student. But in a clinical setting, if it's this guy, I probably need some gloves because they're incontinent. Good? We're going to follow our shoe rules, which means we got to make sure the patient has shoes. If you remember our care plan, it says patient sitting in a chair at the side of the bed with shoes on. Woo! Yay. We're going to put our gait belt on the right way. We're going to ask them if they're dizzy. We're going to count to 3 before we stand. We're going to hold the gait belt from the back as we walk them, all of those rules. We're going to follow our skills specific rules, gait belt over the clothing. We're going to hold on the sides or the back as we lift. We'll let them lead. We walk slightly behind and to one side. We ask them how they feel. We assist the patient to stand and sit. We don't pull the gait belt off across the skin, and we check their body position. And then once we get them seated, we'll do our closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Here's your call light. Your environment's clean. Bed's in low position. Open the curtain. Go wash my hands. My skill is done. They give you 5 minutes to do this. It is a 2-minute skill at best. 5 steps. Doesn't take very long. This care plan is only for this patient. This one walks all on his own. We're not helping him. He's ad lib. He just goes where he wants. This lady, she uses a walker, not a gait belt. And this one, bed bound. We don't even get her out of bed. Every patient is different. Every care plan is different. So I'm going to show you this video. Jake's going to turn it on for us. And then after the video, we're going to take our break. After the break, we have one more skill to learn. And then the rest of the class will be practice. Okay? Good? All right, Jake, take it away.
Hello.
Good afternoon, Mr. Jones. My name is Patty, and I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. Do you feel like going for a little walk?
Yes, that'd be lovely.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. I'm going to clear the walkway of obstructions. We'll close the privacy curtain and wash my hands. Now that I have clean hands, I'll get the gait belt. Mr. Jones, I see you have non-skid footwear on. Does it fit appropriately?
Yes.
Very good. This gait belt I'm going to put around your waist. It's going to help me lift you to a standing position and provide a little stability as we walk. Is that okay?
Yes.
Okay, I'm just going to slide this around your back. Okay, and lift your arms and relax. We're going to put the free end through the first guard by the alligator teeth and pull it so that it tightens the belt. We want the belt to be snug. We want to only be able to fit 4 fingers between the belt and the patient, and then we'll lock it in place by putting the free end through the second guard. And then we'll place the free end through the top just to hold it in place. Okay, Mr. Jones, your feet are together. In just a few moments, I'm going to have you place your hands on my shoulders, and I'm going to place my hands around your back. And on the count of 3, we're going to stand together. Okay?
Okay.
So I'll put 1 foot in front of your feet to keep them from sliding out, 1 foot beside the chair to keep me at an oblique angle. Go ahead and put your hands up here. And on the count of 3, we're going to stand. 1, 2, 3. Thank you very much. Are you dizzy at all?
No.
Okay. So at your pace, when you're ready, I'm going to have you lead and we're going to walk to the wall. I'll walk slightly behind and to one side, watching the patient. Okay, and go ahead and turn. And then we're going to walk back to the chair. Are you dizzy at all?
No.
Very good. So when you get to the chair, if you can turn around for me and back up so that your knees hit the chair, come my way just a little bit. And on the count of 3, can you feel the chair behind you?
Yes.
You're going to place your hands on my shoulders. Go ahead. I'm going to put 1 foot in front and 1 foot beside, and on the count of 3, we're going to lower. Ready?
Yes.
1, 2, 3. Being careful to bend at the knees and not the back. I'll remove the gait belt by taking it out of the second guard and then removing it from the first guard. We're going to remove it by looping it over the patient, being careful not to let any part hit the patient. And are you comfortable?
Yes.
Could you slide back so that your hips are against the back of the chair? Very good. I'm just going to go put the gait belt away. Are you comfortable, Mr. Jones?
Yes, ma'am.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your environment is clean. I'm going to hand you your call light. Here's your call light. If you need anything at all, just press that red button and somebody will be happy to help you. I'm going to open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections that need to be made, and then tell the evaluator my skill is done.
Okay, any questions on that? Any questions? Okay, let's go ahead. Let's see, let me write this down. Let's go ahead and take our break. 15 minutes. When we get back, we've got 1 skill to go, and then the rest of the class will be practice. All right, you ready? Last skill. This does take me a little bit of time to teach you. That I have a few things to talk about, a few new concepts for you to learn. But overall, this isn't a hard skill. We just have to learn a new way of doing it, okay? Not a hard skill. But this is partial bed bath. We should have, keep your fingers crossed, we should have about an hour of practice time, maybe even a little bit more, but this usually takes about 45 minutes to teach. So you should have somewhere around an hour of practice time built in today, which is awesome because my last class did not get that. So I'm doing much better on timing. Yay. All right. So if you look at page 126, we have partial bed bath. Now, if you look at all of the principles we're going to use on this skill, it's almost all of them. The only thing that we don't use is shoe rules that we just learned because they're not getting out of bed. That's the only one that's not used. This skill is going to put into practice everything that we have learned up until this point. So it is a big skill. In fact, it is the biggest skill on the state exam. If you look down here, the test is going to give somebody with your level of experience, which is none, 19 minutes to get this done. This is a 19-minute skill. But the good news is that if you get this skill, you get two super short skills to go with it, like a range of motion and respirations. So it is a long skill, but on the care plan set, remember those sets on page 25? On your care plan set, it's going to be paired with two super short skills. So it's kind of a nice trade-off. All right. So we have to learn our skill-specific steps. The rest of this we already know. This is a mannequin skill. You're going to be doing this on a mannequin, not a live person. That's one of the reasons that I try to give you a lot of practice time in class today, because you've got dentures that you actually need dentures to practice with, and we have a mannequin skill that you're going to need a mannequin to perform it on. So during practice time, you do not have to stay. You are free to leave. This is adult education. I haven't locked the door. I'm not going to make you stay. But I am going to tell you that if you're not practicing here, please make sure you're practicing somewhere. Because when you go to take the state exam, you do not want the first time you do the skill to be during the test. You're not going to perform well your first time. You're just not. Think about the first time behind the wheel driving. You did not perform perfectly. You made mistakes. You're going to make mistakes on skills too. So make sure you're practicing. Use the practice time that we give you in class. That's what it's there for. But if you have shyness, if you don't want to get up and practice in front of other people, you'd rather practice at home, make sure you're practicing. Okay? That's my pep talk. Mannequin will be positioned in bed. This is not a charting skill. You do not have to document anything. If you look at page 127, we have our care plan at the top of the page. We have step-by-step instructions that tell us how to do this skill. We have all of our supplies at the bottom. And yes, there are a lot of supplies. This right here, partial bed bath, face to waist, front and back, face first, no soap. This is the short version of this. So let's take a look at the care plan here. What do we know about a care plan? What do we do with it? Yeah, follow it. Yeah, we read it and follow it. That's what we do. This is a very long care plan. It tells us to give the resident a partial. Let's stop there. Time out. Partial. What does partial mean? Yeah, not full, right? So we are not washing this patient's waist, legs, feet, hairy area, or hair. That's not what our care plan is telling us to do. Partial means that care plan is going to tell us what parts they want us to wash. If you have a care plan that says partial bed bath but does not specify what parts, that's not a care plan. You need to go back to your nurse. Partial bed bath does not mean just these things. It means, for whatever reason, I want you to stay away from parts. Good? Make sense? Okay. This particular one says give the resident a partial bed bath and back rub. We are not massage therapists. We're not deep tissuing anything. We're giving a nice little 3-time circle back rub for circulation to wake everything up, but also to make our patient feel better. When you were a kid, got sick, mom would just come along, rub your back a little bit, and you felt better. That's what we're doing here. But it's going to tell us exactly what to wash because of partial. That word partial says we have to know what it is they want us to wash. So here, wash the resident's face, neck, chest, abdomen, back, one arm and hand. What if they have 2? Just one. You get to pick which one. They don't care. Just one. We don't care why we're not washing the other one. Not our problem. Not our concern. We're just going to do one because that's what the care plan says. With soap and water, it's going to tell you exactly how to get that done. Now, this is actually kind of important, and I want to talk about it really quickly. In acute care settings, hospitals specifically, we aren't giving bed baths with soap and water anymore. They use what we call bed wipes, which they look like baby wipe packages. There's 2 different colors, and they're in a warmer. So the wipe warmer. So when you're told to give a bed bath on those patients, the care plan will probably tell you to use a bed wipe. And this provides an antimicrobial barrier to the skin. So it's a little bit different way of cleaning our patients. So in a lot of clinical settings, you're not going to be using soap and water. We would follow the care plan. Now, those wipes are pretty cool because there's 5 of them, and on the package itself, it tells you exactly how to use them. Wipe 1, cleans here. Wipe 2, cleans here. Wipe 3. So just follow the package. But it's very similar to what we're about to learn. Okay, good. Provide a brief back rub with lotion. We're just making them feel better. Dress the resident in a hospital gown. Patient is lying on back in center of bed and can roll as directed. So we can ask him to scoot toward us and roll, but is too weak to assist with bathing. Now, the problem is she's a mannequin. So I can ask her to scoot toward me all day long, but she's not going to. So we're going to actually have to move the mannequin. Now, the problem with mannequins, anybody ever play with Barbies when you were a kid or G.I. Joes? Yeah. If I have her scoot toward me, Miss Jones, scoot toward me. That's all I have to do. But if I try to put her on her side, okay? So if I try to roll her on her side, remember she has to be in where after the roll? Middle of the bed, right? So she's a little bit too far that way, the top of her body. So I'm going to bring her back, scoot her a little bit more toward me. Now roll. Okay, now she's in the middle of the bed. I'm happy. Pay attention to your patient when you do this. But the problem with mannequins is once I get her on the side, if I let go, what happens? She doesn't stay. Now, I can put any of you in bed on your side. You'll stay on your side. But mannequins, stay. They don't. The evaluators know this. So when you get this mannequin on her side, the evaluator will come around to that side of the bed and just him for you. That's nice. We like that. Okay. All right. Good. Good. Okay. So let's get into this skill. So we already know all of these, right? We know to follow the care plan. We know every skill starts with an opening. Every opening starts with a knock. We know to wear gloves because we're going to be around doorways. We know to use a barrier on our table to keep everything clean. We know to use a privacy blanket to keep our patient covered. We know linen rules, don't hold them against your uniform. Nothing goes on the floor. We know the patient must always be in the middle of the bed. We know to clean our basin the same way we clean everything, rinse it, dry it, store it, and we know how to do the closing. We know all of this. But what we don't know is one of the steps of washing rules. And I told you we're going to come back to this one. So let's learn this right now. This is the very, very last principle that we need to learn. Before I show you that, I want to review our washing rules. Basins are no soap zones. We don't put soap in the water so that we have clean water for rinsing. We use a paper towel to turn the water on. We're going to check it. It should feel warm, not hot, not cold, just warm. And who else checks it? The patient checks it. Whatever we wash, we rinse. Whatever we rinse, we dry. And we change the water if it gets cold or soapy. We try to keep our dry surfaces dry. So in this case, we're working on the bed. We're going to put something underneath the patient so that we don't get the sheets wet. And if we're going to put lotion on, we warm it up first and wipe off the excess. We know all of those rules. But I want to come back to this one because this one's been blanked out and we need to learn it. And this is called the leaves method. We use the leaves method for wet body openings. Do you guys remember what a wet body opening is? Eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, or incisions. Doorways. Places that pathogens can get out of the body, but also pathogens can get into the body. If we're going to be washing any of these, we need a special way of washing them. Good? And that's what I'm going to show you right now. Bless you, Jake. So if you take a washcloth, just a plain square washcloth, and Jake just handed these out to you guys, a plain square washcloth. If you fold it in half and then in half again, we get a smaller square. Okay, smaller square. Good? You guys probably have these hanging out in a linen closet somewhere. But instead of looking at it as a square, I want you to turn it a quarter turn and look at it as a diamond. We're going to use diamonds. Now, I need this in a very specific way, though. We want this positioned in a diamond with all of our free corners at the top, not a folded corner, not here, not here. I need the free ends at the top. Good? Okay. If you've got it a diamond, free ends at the top, take your hand, your dominant hand. So if you're right-handed, use your right hand. If you're left-handed, use your left hand. So take the washcloth and put free ends up, just like that. Now you're going to tuck in one of the sides between your thumb and index finger to hold it in place. The other side goes between your pinky and ring finger. Okay. Like this. Good. Good. Between your pinky. There you go. Yep, just like that. Is everybody good? Yep, just like that. Good. Did you not get one? You didn't get one? Oh, we need two more, Jake. Sorry. Okay. Good. Got it? Okay. So now if I'm going to wipe a wet body opening, so let's say I want to wipe an eye. I'm going to take the top corner here and inner to outer corner, and then I can fold that over, and that traps the contamination underneath. Good? Good? Good. Okay. Then I can take the second leaf and wipe another eye, inner to outer corner, and fold it over, which traps the contamination underneath. Now I've got a clean area to work with. Now I can wipe the rest of the skin, right? Whatever I need to wash, I can fold that over, trapping the contamination underneath. And now the last one, I'm going to wipe the nose with. Now I do the nose last because boogers. Okay. And then I can fold that over, trapping the contamination underneath. And if I needed it, I could use the outside as my fifth area if I needed another area. But the whole point here is to make sure that for every wet body opening, you're using a different area of the washcloth. So we're not taking germs from here and putting them here.
So the nose and mouth are two separate as opposed to...
Right. Because
Right, because they're separate wet body openings, yes. And this, yes, I understand anatomy, that they're joined in the back at the pharynx. I understand where you're going with that. But the thing is that I don't want my patient to taste their boogers, you know, because mouth has taste. Good? Does that make sense?
Yes.
Okay. So we treat every single body opening as a separate area, even if they're joined, and we use a separate leaf. Now, if we're working with incisions, we need a separate leaf than anywhere else. If we're working with wounds, if I have a wound, well, I do actually. Let me see if I can pull my leaf. I don't know if you can see it. Oh, there it is. See how I've got an open sore right here? I can't hardly see it. It's scabbed over pretty well. If I had it was open yesterday. If I had a skin opening, if I were to wash around it, I would want to use a different leaf because I don't want to take stuff from that opening if it was weepy and spread it along the skin. Does that make sense? So around that, I would use a leaf, fold it over, and then wipe the rest of the skin. Now, if the skin is intact, like this is all intact skin. There's no skin openings here. I would just use just a single leaf to wash everything that's intact. There's nothing here I need to worry about, right? No skin openings. It's only when we get to skin openings that we need the leaves, that we want to change the leaves. Good? Thank you, Jake. So our skin openings are eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, and incisions. These are all what we call doorways. Doorways in, doorways out. So one more time, let me show you because I know this is kind of a hard concept. So if I have my washcloth folded as a square in my hand, tuck my corners, free leaves at the top, I can wipe something. I can then fold that leaf over. I can wipe something else. I can fold that leaf over. I can wipe something else. I can fold that leaf over. I can wipe something else. I can fold that leaf over. And then the back side, I can even wipe something else if I need to. Now, when I'm done, can I throw it on the floor? I'm going to put it on an unused part of my barrier for later. And then when I'm all done with the skill, I'll take all of my linens and put them into soiled linen. They don't go on the floor. Putting them on an unused part of the barrier, fine. Do I want to put it back in my basin of water though? No, because it's got ickies on it. Okay, so keep your clean and your dirty separated. Questions? Okay, now we know all of those things that we need to learn. Now let's learn our skill-specific steps. We know all the principles that tell us how to do the skill. Let's learn about the skill itself. So we're going to follow what's on the care plan because we know we have to follow the care plan. But a lot of these steps on the checklist are specifically about the care plan. So make sure you understand that care plan. Now, if you go back to page 127, I pointed out that little square where I said face to waist, front and back, face first, no soap. That's the short version of this. Face to waist, right? So face, neck, chest, abdomen, side, one arm and hand, face to waist, front and back. But when it comes to the face, we're not going to use soap. And we're going to talk about that now. No soap on the face. Soap stings the eyes. It dries the skin. We don't use soap on the face unless the patient specifically requests it or the care plan specifically tells us to use soap on the face. No soap on the face. For the test, no soap on the face. Good. There are some patients that have very, very, very oily skin. And their care plans may have us use a special soap on the face to help remove some of that oil. That's probably a little different than body soap because body soap can be very drying. We're going to follow our care plan and remember that there's all kinds of different skin types out there. All right. So face first, no soap. What that means is I'm going to take my washcloth, I'm going to wring it out really well, no drippy wet washcloths. I'm going to hold it in my dominant hand. I'm going to tuck in my 2 side corners, and I'm going to take the first leaf on top, and I'm going to wipe inner to outer corner of that eye. No soap. No soap on the washcloth. I'm going to fold that over. I'm going to wash inner to outer corner on that eye. I'm going to fold that over. No soap. I'm going to wash the forehead, the cheeks, the bridge of the nose, down around her mouth, and I'm going to fold that over. And then the last one, I'm just going to do that nose. I'll fold that over and put it on my barrier. Now, we didn't use soap here, so I don't have to rinse, because whatever I wash, I rinse. No soap, so that was my rinsing. So what do I do after I rinse? Whatever I rinse, I dry. So I'm going to get a towel and dry those areas. Now, we don't have to use a different area of the towel. We simply take a towel and we're going to dry. Now, the problem is if I do this, okay, I'm beating her up. I want to control my towel. So I'm going to take the towel in the middle. I'm going to put my four fingers, my thumb on the back. So I'm going to hold it like this. Good. I wrap it around. And now I control my towel. Okay. So you put 4 fingers down in the middle, wrap around, and then fold it over. And now you've got a controlled area to dry with. Good? Good? Okay. Hold that for me. Okay, so we're going to use that leaves method with eyes, nose, mouth, genitals, anal area wounds, sores, rashes, and incisions. I know you've seen this slide a lot because it probably will show up on your written test. Control that washcloth. Now, our checkpoint, I want to be very specific on this. Our checkpoint says contain corners of washcloth while washing and rinsing, e.g., for example, forming a mitt. Now, you can do that. You can do that. Let me show you how to form a mitt. To form a mitt is a little bit different. I'm going to show you why the leaves method is better in a minute, but let me show you how to form a mitt in case you want to do that. To form a mitt, you take the washcloth, okay? You fold it around the fingers like this, overlapping. I'm sorry, let me back that up. Do it the other way. You want the overlap on your finger side. So like this, wrap it around and overlap like this. Okay, so you made a tube. And then you fold this long end up over and tuck it in the opening. So now you've got like a mitt. And it controls the area of the washcloth. The problem is that this doesn't keep germs from this eye getting into this one. I go here. I don't have anywhere else to go, so I go here. And now I've used the same area of the washcloth, and that's a problem because that is a checkpoint as well. So yes, you can use a mitt when you're washing the rest of the body, but when you're washing that wet or those wet body openings, use the leaves method. Okay. I use the leaves method for everything because it's convenient. But yes, a mitt will work as well. And I want to show you how to do that. No drippy wet washcloths. Bring those washcloths out thoroughly. Don't return a soapy washcloth back to the basin. Rinsing washcloths can go back in the basin though, no problem there. If you use a washcloth to rinse, you can put that back in the basin as long as it didn't touch any wet body openings. So if I use one washcloth to wash my whole upper body, down one arm, up the, I set that aside, it has soap on it. But then I rinse all those areas, the neck, the chest, the abdomen, the side, one arm and hand. I've rinsed. No soap on that washcloth, so I can put that back in the basin and use it on the back. Okay, good. Set your washcloths aside on the barrier. Don't return them to the basin. Nothing with soap or body fluids goes back in the basin. The only thing that can ever go back into a basin is a rinsing washcloth that did not touch a body opening. Now, for the test, if you go back to page 127, you'll see the supplies for this. Do you see how I have 4 washcloths there? I'm going to show you how to do this with 4 washcloths. So the washcloth that rinsed the torso, You can use it to wash the back later for washcloths. For the test, you can use 5. Makes it easier. 1 and done. Use a washcloth, set it aside. Don't use it again. Use a washcloth, set it aside. Don't use it again. Fine for the test. But in a clinical setting, you're going to find a situation often where you do not have enough washcloths. There are never enough washcloths or towels in a clinical setting. And one of the reasons for that is that CNAs come on shift, they get their report, they run into the supply room, grab all the supplies they think they're going to need for their shift and go hide them somewhere. So now you come along and you're like, I got to give a partial bed bath, and you walk in and you got 2 washcloths and no towels. How are you going to be able to do your job if you don't have enough supplies? This is an ongoing problem. Don't be that CNA. Okay? Don't be that CNA that hoards supplies. But you need to know how to do these skills with as few supplies as possible, which is why I'm teaching you this method. Anything that has rinsed, that does not have body fluids or soap on it, can be reused. Just remember that if you need it in a clinical setting. Good? All right, so let's back up real quick. We wash the face. Eye, leaf, folded over. Eye, leaf, folded over. Face, leaf, folded over. Nose, leaf, folded over. Set it aside. Dry. Washcloth wrung out. Soap to the top. You wash the neck, the chest, the abdomen, the side, down one arm, hand, up the back of the arm, armpit last because gross. Has soap on it. Set it aside. We're going to get another washcloth. We're going to wring it out. We're going to rinse neck, chest, abdomen, side, down the arm, hand, up the back of the arm, armpit. That we can put back in the basin and use it for washing in a minute. Scoot the patient towards you. Roll them on your side. Evaluator will hold that mannequin. And then you're going to wash, rinse, and dry the back. Good? Once we've got the patient's back dried, then we will give them a little bit of a back rub. This is waist to shoulders, small circles 3 times. Waist to shoulders, waist to shoulders, all done. When we use lotion, we warm it up first and then we wipe off the excess. Good? If you go back to that care plan at the top, page 127, it's going to tell you that the patient needs to be in a clean gown. After clean body needs a clean gown. That just makes sense. Now, when you put them in a clean gown is totally up to you. Totally up to you. I'm going to show you the fastest way because I'm all about speed. I got way too much to do and not nearly enough time to do it. So let's back up here real quick. Okay. I got a patient laying here. She's got a gown on. I have to bathe her. I've also got to protect the sheet. So I'm going to lean her forward. I'm going to put a towel under her, untie her gown, and I'm going to take it off of the side I'm working on. How many arms did a care plan tell us to wash? 1. So I'm going to take it off of this arm. I'm going to push it over to the other side. I've got a naked torso under here, 1 arm and hand that I can wash. So I'm going to wash her face, set that washcloth aside, or rinse her face, set that washcloth aside, and dry. I'm going to get a washcloth, wring it out, put some soap on it. I'm going to wash the torso. Under the chin, across the neck, top of the chest, under the breast, down to the abdomen, up the side, down 1 arm, hand, back up the arm, armpit last. Let's set that aside. I'm going to get washcloth number 3, wring it out, and I'm going to rinse all those areas. Under the chin, across the neck, upper torso, around the breast, down to the belly button, up the side, down the shoulder, to the hand, up the back, armpit last. Put that in my basin, and I'm going to dry all of those areas. Neck, chest, arm, side, dry. Good. I have to turn this patient over to take care of her back. It is better, quicker, more efficient to dress her first. So I'm going to put her gown on here, take the gown off of that side, that arm, put it on, scoot her toward me, roll her up on her back, wash the back, rinse the back, dry the back, give her a back rub, and now all I have to do is tie the gown. Quicker. Otherwise, here's what happens. I wash the front, I rinse the front, I dry the front, I scoot her over, turn her on her side, I wash the back, I rinse the back, I dry the back, I give a back rub back onto her back in the middle, take the old gown off, put the new gown on, scoot her toward me, roll her on her side, tie the gown, put her back on her back in the middle of the bed. That's a whole lot more work for me and a whole lot more time. It's okay for the test. If you want to do that, you go right ahead. If you forget to put the gown on before you flip her over, it's fine. There's no graded checkpoint on this. But I'm telling you, for time management, it is much better to get her dressed before you flip her on her side. Good? Good. So the best thing to do is to change the gown. Remove the soiled one, put the new one on before you turn the patient. Then once you're done, you can just tie that gown and you're done. So let's look at these checkpoints and how, that's a lot of steps. Oh my gosh. So can you imagine what this checklist looks like? Let's take a look. This is the checklist. There's a lot of steps here, guys. There's a lot of steps here, but I want to show you something really cool, okay? A lot of steps, but take a look at this. We're going to follow our care plan, and we're going to get 3 check marks for that. We're going to do our opening, and we're going to get those check marks. We're going to wear gloves and get those check marks. We're going to use a barrier on our table and get that check mark. We're going to use a privacy blanket and get that check mark. We're going to follow our linen rules, nothing on the floor, nothing against our uniform, and we're going to get that check mark. We're going to, we're not going on break, no. We are going to use a, scoot and roll, keeping our patient, We're going to use our scoot and roll, keeping our patient in the middle of the bed. Buttons here. We're going to use our washing rules. Look how much we got for just washing rules. We're going to do basin cleaning, the way we clean everything else. Are you noticing that we haven't even got to the actual skill yet, and we've got most of our check marks? And then we're going to do our skills-specific steps. This is a huge checklist, but look, that's it for this actual skill. So remember some of the others, it was mostly like half were skill-specific steps. This one, it's all this other stuff that you have to show that you know. The actual washing, 5 steps. That's it. And then we're going to finish up with our closing and get those check marks. Questions?
At the exam site, are we using water to wash the whole
Real water, real soap. Yep, real lotion. So you're really going to be putting lotion on this mannequin. Please make sure you wipe it off with a towel. For the test, we use spray soap. It'll be a larger version of this, but it's spray soap. Spray soap does not suds up, and that's kind of the whole point of it. Your patient isn't under running water. We don't want suds. Okay? But yes, it is a simulation skill in the fact that we're doing it on a mannequin. But other than that, it's real. You're really going to wash her for real. This care plan is only for this patient. This one goes to the shower room. That's taken care of. This one bathes herself. She doesn't need us. This one gets a bed bath, but it's not a partial. He gets bathed top to bottom twice a week. Every patient has a different care plan based on the needs of that patient. Good? Questions? Okay, I'm going to show you this video, but guys, it's a long video. It is. It takes like 12 minutes. It's a long video, but it has really good close-ups of each one of these steps. And please remember that after wait till I sign off. Jake will be passing out your review sheets too, but wait till I sign off, okay? And then I'll open it up for practice for you guys so that you can practice these same steps with the same supplies, with the mannequins, with the dentures, if you want to do denture care. All of the skills that you've learned, you'll be able to practice in here. Try not to practice anything we haven't learned yet, though. I'm not done with you yet. I still have 3 more classes to go. Okay? All right, Jake, take it away. Good morning, Miss Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I'd like to provide a partial bed bath. Is that okay? Wonderful. I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. Now that I've washed my hands, I can gather my supplies. I'm going to place the supplies on the overbed table. We'll start with a barrier, unfolding the barrier so the absorbent side is facing up, and this gives us a clean place to put our clean supplies. For this skill, we're going to need 2 towels, 4 washcloths, 1, 2, 3, and 4. I need a privacy blanket and a clean gown. Being careful not to hold the clothing against your uniform. I'll bring this over to the patient area. We'll bring this over here within reach, and then I'm going to get the supplies out of the drawer that I need. We're going to open the middle drawer and remove the basin, soap, and lotion. I'll put these on the overbed table. And I'm going to get a set of gloves. Okay, Miss Jones, I'm just going to get some water in the basin. I'll be right back. I'll use a paper towel to turn the faucet on. Check the water temperature with the inside of my wrist. It should feel warm, not hot, not cold. And we'll fill the basin about a quarter of the way full. Okay, Miss Jones, I have the supplies here. Would you like to check the water temperature and make sure it's okay? It's good? Very good. Okay. So I'll put the washcloths in the water. And the first thing that we're going to do is place a privacy blanket over you. This is going to help keep you warm and provide privacy while we do this skill. We're going to spread this out without snapping it or shaking it. Placing it over the sheet. And I'm going to pull your sheet down to just below your waist. Okay, now I'm going to put the towel on the bed. This is going to help keep your sheets dry, and we'll untie your gown. So I'm going to help you sit up by putting my hand on your upper back, and on the count of 3, we're going to sit. 1, 2, 3. Very good. I'm going to untie your gown. And then we'll spread that towel out underneath the areas that we're going to wash. Come on back. Very good. And I'm going to remove the gown on the side closest to me, supporting at the elbow as I lift. Okay, Miss Jones, go ahead and bend your elbow. Thank you. And then we'll move the gown over to the other side, making sure that you're covered at all times. Now we're ready to start washing, so I'll go ahead and put my gloves on. We'll take the first washcloth, wring it out really well, and then I'm going to hold the washcloth in my hand so the free leaves are at my fingertips, and tuck in the 2 side corners. And this allows us to use a different leaf for each area that we're going to clean on the face. After wringing out the washcloth, no drippy wet washcloths, we're going to wash your face first. I'll start with your closest eye, and we're going to wash inner to outer corner using the leaves method, which is going to help prevent cross-contamination. So with the first leaf, we're going to wash the inner to outer corner of this eye. We'll fold that leaf over. And with the second leaf, we'll wash the inner to outer corner of that eye. Fold that leaf over, and with the third leaf, we'll wash the remaining skin of the face. We'll fold that leaf over, and with the last leaf, we'll wash the nose. And we're going to put this on the barrier. Whatever we rinse, we dry. So I'm going to take the towel and fold it around my hand so I have control over it, and I'm going to pat all of those areas dry using short, soft strokes or a patting motion. We'll set the towel aside. Okay, now we're going to take washcloth number 2 and wring it out really well so that it's not drippy wet. And then we'll apply soap to the top leaf. We're going to start cleaning the neck, behind the ears, under the chin, across the neck, the upper torso, down to the breast, keeping the patient covered at all times to protect modesty, down to the belly button, and up the side. Now, for the test, you will keep the patient covered. The evaluator will ask you to move the blanket if they would like to see. I'm going to go ahead and remove the blanket now so that you can see what I'm going to do. So we're going to move the blanket down, and I'm going to start again to show you how to clean the patient. So under the chin, behind the ears, across the neck, the upper chest, around the breasts. When you lift the breasts, we lift not with the palm, but with the back of our hand to lift the breast to clean underneath, down to the belly button, up the side, down the front of the arm, all the way to the hand, supporting the elbow at all times, either with your hand or the bed, up the back of the arm, and we'll clean the armpit last. We're going to set that on the barrier. Whatever we wash, we rinse. So I'm going to get a rinsing washcloth, and we're going to rinse all of those areas the same way. So behind the ears, under the chin, across the neck, upper torso, around the breasts, down to the belly button, up the side, down the shoulder and the front of the arm, supporting the elbow, the hand, lifting the arm from below, washing the underside of the arm and the armpit last. We'll set that washcloth back in the basin for future use. We're going to take the towel, controlling the edges, and we're going to pat all of those areas dry or use short, soft strokes. Nothing vigorous. So the abdomen, down the arm, lift the arm up, support at the elbow, dry the hand, lift the arm to dry the underside of the arm and the armpit. We'll set this aside. Now, the care plan only asked us to clean one arm. So we don't have to go over and clean the other arm. And that's because that's what the care plan instructed. In some cases, you will have to clean both arms. In that case, you would just do that at this time. But for right now, we only had to clean one arm. We did that. So we're going to dress the resident in her gown. I'm going to spread the gown out, put my hand in through backwards on the armhole, lift her hand by holding her fingers together to place the sleeve over the arm, and then I'll lift at the elbow to bring the gown up. I'm going to make sure that gown is covering her. Put the privacy blanket back in place, and now I'll go to the other side of the bed to remove the old gown and put the new one on. Okay, now I'm going to move the blanket and remove the gown from this arm by sliding it off the arm, lifting the elbow from below with a flat palm, and then this will go in dirty linen. Now I can put the new gown on this arm by putting my hand in through the armhole backwards, grasping her hand, and sliding the gown over. We're going to lift from below at the elbow and make sure that the gown is properly in place. Now I'm going to go back to the other side of the bed. Okay, Miss Jones, I'm going to wash your back now. So I'm going to pull you toward me and turn you up on your side, and that way you're in the middle of the bed after the turn. Okay, go ahead and slide toward me. And then you're going to roll on your side. 1, 2, 3. Thank you very much. The evaluator will hold the mannequin in place during your cleaning, during the test. Live patients, of course, can lay on their side. So I'm going to ask the evaluator to please hold the mannequin in place for me. Thank you. We'll slide this towel down so it's covering the bed underneath the back. We're going to take our third washcloth, wring it out really well, and we'll apply soap to the top leaf. I'm going to wash the back from the neck down to the shoulders, all the way down to the waist. We'll set this washcloth aside, and we'll get our rinsing washcloth. So we'll wring that out, and we'll rinse the same way we washed. The back of the neck, the shoulders, all the way down to the waist. We'll set that aside, and we'll take our towel to dry those areas. So I'm going to pat dry or use short, soft strokes and dry all of those areas. Now the care plan asks me to provide a brief back rub. So I'm going to take my lotion, put a little bit in my hands, and then I'm going to warm it up by rubbing my hands together. We're going to start at the base of the back and go up in small circles to the shoulders, and we'll do this 3 times. To the shoulders, come down, up to the shoulders and come down. And then we'll take the towel and wipe off the excess lotion. We'll remove that towel from the bed, putting it on the overbed table, and then we'll tie the gown. Come on back, Miss Jones, onto your back, and then scoot to the middle. Thank you. Okay, you're covered and safely in the middle of the bed. Let me go dispose of all of my supplies, and I'll be right back. So I'm going to put all of the supplies in dirty linen, being careful not to hold them against my uniform. And now I'm going to clean my basin, and we'll dispose of the water in the sink. Rinse the basin, and then dispose of the rinsed water into the sink as well. I'm going to set that down, disinfect it per facility policy, and then pick it up with a paper towel. I'm going to get a clean paper towel to dry the inside. I'm going to get a clean paper towel to dry the outside. And then one more for the drawer. Okay, on the way, I'll place the lotion and the soap into the basin using a paper towel. And then I will use the paper towel to open the middle drawer and slide the basin with the soap and lotion into the drawer. We'll close the drawer with a paper towel and then throw them away. I'm going to remove the barrier, throw it away, and then I can remove my gloves. Okay, Ms. Jones, I'm going to move your privacy blanket now. So as I pull the blanket up, I'll restore the sheet. This preserves modesty and keeps the patient warm. We'll roll the privacy blanket up in a ball so that trailing edges don't contaminate other surfaces. Okay, I'm going to place this in dirty linen. We'll return the table to storage. Adjust the sheet for neatness and appearance. Okay, Miss Jones, are you comfortable? Is there anything else I can get for you while I'm here? Okay, let me place the call light in your hand. So there you go. The call light is in your hand. If you need anything at all, please press that red button. We'll be happy to come help you. Bed is in the low position. The environment is clean. I'm going to open your curtain and go wash my hands. After washing my hands, I'll review the care plan to make sure that everything in the care plan was addressed with this skill. I'll think about my skill and make any corrections that need to be made. And once I'm happy, I'll tell the evaluator my skill is done. Yes. All right. Any questions on that skill? It's a super long skill, but there's not a lot of new stuff in it other than the leaves method. Everything else is something they should be pretty familiar with. Good? Good? All right. Jake handed out your review sheet. Your homework between now and Wednesday is going to be chapter 7, which is another skills chapter. Make sure you're reading the paragraphs in between the skills. We are sending out your review or your after class wrap up emails. So make sure you check your email for that. And then this is the QR code for the CPR class. If anybody needs that CPR class, this will take you to their to Julie's registration page. Julie's the one that's in and out of here. This is her classroom. This will take you to her registration page, but specific for our students, so it auto applies your discount. You don't need it for the test. You don't need it for my class. You will need it to work. Most healthcare settings require CPR. Okay. And then, of course, you got your review sheet. Any questions before we sign off? Jake, anything online I need to address? All right. Well, we will see you guys on Wednesday for class 6. Oh my gosh. The end of week 3. There's only 3 classes left, guys. We're getting there. Goes fast. All right.